We have come to gather information. Information is the gateway to life of advancement and is cure for all of man's frustrations. And we cannot do better except we know better. So we are all welcome to this scientific conference. Bloodless Medicine and Surgery is a multidisciplinary professional society of experts and stakeholders in clinical care without the use of donors' blood, with the aim of improving clinical outcome and protecting patients' rights. Bloodless Medicine and Surgery is an organization affiliated to Society for the Advancement of Patient Blood Management. This is the 9th meeting of Bloodless Medicine and Surgery, and the theme for this year's conference is Compassion at the Art of Bloodless Medicine. It promises to be a great time, it promises to be an informative time. And at this point, it is my privilege to introduce my co-moderator, Dr. Sue Lewis, a professor of pediatrics hematology, director of pediatrics sickle cell, University of Illinois at Chicago. Let's make welcome my co-moderator, Dr. Lewis Chu.
Thank you, Dr. John Ogbagde. I'd like to welcome all the attendees to this particular session of the symposium. This is a symposium entitled Medical Ethics and Medical Legal Issues in Bloodless Medicine. And I'd like to introduce the first speaker, Dr. Roland Ndoma Egba. Dr. Egba, MBBS, FRCS, is a professor of surgery at University of Calabar, Nigeria. He received his degree in medicine and surgery from the University of Lagos in 1977. He became a fellow of the Royal College of Surgeons, Glasgow, in 1986. He's also a fellow of the West African College of Surgeons. Dr. Ndoma Egba has served as Chief Medical Director of University of Calabar Teaching Hospital for 2 tenures. He's also former Pro-Chancellor of Obafemi Awolowo University in Ile-Ife. Dr. Ndoma Egba is widely published and has received several awards, including the 2015 Award of Excellence of the Bloodless Medicine and Surgery Society, for his excellent contributions to the science and practice of bloodless medicine and surgery. He's the chief patron of the Bloodless Medicine and Surgery Group, UCTH, and is a member of several professional societies, including the Bloodless Medicine and Surgery Society, of which he is a life member. Welcome, Dr. Ndoma Egba.
Okay, Dr. Sue. Your pronunciation has earned you a title amongst my people, because you called it like someone from my village. So thank you so much for introducing me. Good afternoon, distinguished ladies and gentlemen, and from wherever you're watching us, I wish we have a good day. I would like to present my slides now. Okay. My part of the discussion is on compassion and essential quality for ethical surgical practice. As far as discussions go, I have none except my dear granddaughters, whom I'm very proud of and I love very much. Beyond that, I have no other disclosure. As plan of my discussion, I will start with introduction and definitions, characteristics of ethics, conceptualizations and explanations, interpersonal factors associated with compassion, action and practical compassion in healthcare, cultivating compassion, and most importantly, can compassion be taught? How do we teach compassion, if so? And finally, the conclusion. As a matter of introduction, I've taken the liberty to give the simplest, non-complex, non-professional or not specific to any profession definitions to the title of my presentation. And for this, I've used the Oxford Advanced Learners Dictionary 10th edition. Compassion is here defined ordinarily as strong feeling of sympathy for people or animals who are suffering and a desire to help them. Quality is the standard of something when compared to other things like it. And ethical is connected with beliefs and principles about what is right and what is wrong, morally correct or acceptable, and usually defined by each group of professionals. Surgical practice here is the branch of medical practice where treatment involves manipulating or cutting open the human body, often removing or replacing parts, and sometimes not even using surgery. Characteristics of ethics. We will remember that the Hippocratic Oath summarizes medical ethics and has evolved over the years with various modifications in keeping with changing times. The seeds of surgical ethics as a specific component were sown by John Gregory and Thomas Percival, who explicitly specified the moral values of a surgeon in the 19th century. Pillars of surgical ethics. One of the most important pillars is autonomy. Autonomy implies that the patient has the freedom of thought, intention, and action when making decisions regarding surgical treatment and care. This also implies other branches of medicine. Beneficence, the surgeon should always act in the best interest of the patient and no other consideration. Non-malfeasance, above all, do no harm. Non-nocere, as in the original, must exercise sound judgment and recognize limits of professional competence. Justice, surgeon must observe policy of fairness and equality of all human beings. Although compassion is vital across the entire healthcare field, it is central goal and tenet of palliative care. Empathy, the Latin root for compassion, is pati, which means to suffer, and the prefix com means with. Compassion originating from compati literally means to suffer with. The connection of suffering with another person brings compassion beyond sympathy, which is appreciating a person's pain and suffering, into the realm of sympathy, which is wearing the patient's shoes. But beyond that, compassion also requires action. Definitions of compassion differ according to the perception from which it is defined. Patients view compassion as a virtuous response that seeks to address the sufferings and needs of a person through relational understanding and action. Healthcare providers view a virtuous and intentional response to know a person, discern their needs, and ameliorate their suffering through relational understanding and action. It is recognized as a standard of care and a core component of patients' healthcare experience. Compassion is how care is given through relationships based on empathy, respect, and dignity. It can also be described as intelligent kindness and is central to how people perceive their care. Competence means all those in caring roles must have the ability to understand an individual's health and social needs. Values of a compassionate system. The 6 C's, according to NHS of UK, recognizes care, where you help the individual and improves health of the community. Improving the health of an individual also improves the health of the community. Compassion means giving care given through relationships based on empathy, respect, and dignity. Competence, all those in caring roles must have the ability to understand individual needs, must have expertise, clinical and technical knowledge to deliver effective care based on research and evidence. Communication, central to successful caring relationships and effective teams, and function of effective teams. Courage to do the right thing, to speak up for the right thing, and to stand for the right thing, no matter how many persons differ. And that is why in Bloodless Medicine, new as it is, although strange to some persons, it does not mean we have got to give up on fighting to make sure that it is institutionalized. Commitment on the patients and the population, the cornerstone of all activities. Benefits of compassion. Compassion has been associated with positive impact on patients' experience and patients' reported outcomes. It has reduced patients' symptom burden and improved quality of life. It leads to the enhancement of quality of care rating of any system that adopts compassion methods. Characteristics of a compassionate surgeon. A compassionate surgeon recognizes suffering and vulnerability. He seeks to understand the unique circumstances of each patient because they must be different, attempts to alleviate the patient's suffering, and accompanies the suffering and vulnerable patient to a comfortable zone of outcomes. Where there is lack of compassion, it's been observed and has been shown by research that there is increased patient-family complaints, increased health costs, and increased adverse health outcomes. The surgeon and compassion. The surgeon imagines himself or herself as a patient with fears and concerns that go along with being ill. He or she steps alongside the patient, acknowledging their concerns and guiding them into an area of health and wellness through the correction of the illness. Compassionate approaches to healthcare are pleasurable, increase social connections, decrease focus on self, and protect against stress. Whether on the patient side or the surgeon side, the benefits abound for both. The pillars of blood patient management. These are the original pillars of blood patient management as proposed by the WHO. The one that we optimize the patient's hematocrit before surgery, minimize blood loss at surgery, and support patients' tolerance of anemia. The pillars of bloodless surgery, on the other hand, by bloodless medicine, in addition to the 3 by the WHO, which includes to optimize hematocrit, minimize blood loss, is also to optimize tissue oxygenation, in addition to support physiological tolerance of anemia. Factors signifying compassion: kindness forming relational connection, authenticity, displaying presence and warmth, acceptance, understanding, and listening, in addition to helping the patient, communicating effectively, being involved, being caring, and gentle. In summary, a virtuous response that seeks to address suffering and needs of a person through relational understanding and action. That's by Sinclair et al. Cultivating compassion. Nefsley et al. In 2015 did say compassion is an innate emotion and part of one's personality at birth. Several studies, however, show that compassion can be taught, and practitioners equipped with tangible skills for improving their professional practice by clinical role modeling, a supportive environment, adoption of reflective practice, and Reynolds et al. Talked of use of compassion involving images to combat clinical scenarios that challenge health personnel's ability to be compassionate with patients with disgusting symptoms. One will agree that this is a major challenge. Patients are presenting with, in quotes, disgusting symptoms. These are often not intentional, and therefore the ability to use compassion involving images as proposed by Reynolds is a way of combating the inability of some healthcare workers to be compassionate with. The ability of health workers to interact with patients, to deeply share in their experience through their outward expression of their innate virtues, and creating a relational space to do so is paramount to provision of compassion in healthcare and entails being physically present with the patient, seeking to understand their unique needs and emotions, and appreciating the person as a person. Relational factors. Skills such as being able to express affection, kindness, tenderness, being able to actively listen, showing understanding, being supportive, were perceived to be more effective expressions of compassion than routine task-oriented care. Clinical communication. A prominent component of compassion in healthcare is clinical communication. Compassion models relational communication refers to verbal and non-verbal displays of compassion and include by the demeanor of the health worker, by the affect, emotional resonance with the patient, by engagement and behavior, actively listening, especially to the subtext of what is not said, being attuned to nonverbal cues, using silence, paying attention to tone of voice, can help uncover patients' concealed suffering. Taylor et al. 2020 tried to differentiate communication into indicative communication and traditional communication, such that indicative communication takes body language must be accompanied with tone of voice to demonstrate a compassionate intent. Other forms include personalization. Patient will feel more comfortable if there is personalization of this attention and care. Attentiveness as to active listening, body language, including smiling, eye contact, and even touch. From the patient's view of compassion, the patients regard compassion as a display of emotion that could help humanize the interaction with patients. Perception may also depend on content of the message. For instance, physicians who provide more optimistic prognosis were considered more compassionate than physicians who went on to give prognosis that wasn't favorable. Euphemisms may be better preferred than the raw stuff. Action and compassion. Action-based components directed at proactively alleviating patient suffering and addressing their needs through tangible means are considered quintessential. Small acts of kindness, such as providing comfort, performing actions that are beyond the call of duty, going above the call of duty with expectation of nothing in return. These were thought to be compassionate. Rose de Ordonez et al. Advised that we avoid overly biomedical approach, which may represent over-medicalization of an illness. There is need to have competency in the relief of pain, both by pharmacological and non-pharmacological means, because sometimes pain is just supratentorial. Challenges to compassion, practice setting. There is no doubt that to be compassionate requires a lot of attributes, including having enough time to spend with the patient so that they can recognize those verbal and even non-verbal communication skills. Organizational culture, the system must recognize compassion as an integral part of the service they offer, and therefore create that organizational structure that allows the health worker enough time to interact with patients. The issue of excessive workload is universal, and many times the health worker is so overworked that he or she cannot afford both the patients and the luxury of paying adequate attention to a patient who needs compassion. Inadequate staffing is another challenge. The clinical environment itself may be such as to detract from the ability to spend quality time with the patient. Advancing technology many times does not allow for the time lapse that should take place, and with the speed of looking after so many patients can become mechanical. Sims et al. Call it intentional rounding, where you just go on without actually spending time to understand the patient. Lack of managerial engagement or support can make it extremely difficult to practice compassionate process. Educational challenges. When there is perceived incongruence between theoretical knowledge and ability to apply it, we say there is compassion distress. And this happens very much with virtually all levels of care, but especially people who are new on the job and who find that in as much as you've been told about patients with abnormal or disgusting symptoms, in quotes, when you come to facing them, there may be a disconnect, and you have what we call compassion distress. Absence of enabler role models who are there to transfer the skills. In the absence of such enabler role models, acquiring the skills can be very difficult. And finding even the enabler role models themselves is difficult because compassion is as old a word as it has been, in terms of taking it on as a cardinal issue in medicine, is only a recent event. Experiential teaching is better than didactic teaching, where you demonstrate clearly how to calm a patient in distress down, how to comfort a patient in distress, and how to take away their pain or suffering is a better taught thing in practical terms. The more educated patients tend to rate staff as less compassionate. Interventions. Gould et al. Have talked of creating an environment for compassionate care, the process of CLEC, to enhance clinicians' ability to give compassionate care. This process can be used to teach some aspects of compassion. Using patient evaluation of emotional care during hospitalization to score performance. Using this technique, it is possible to evaluate, by using the patients themselves, the level of compassion shown by the different caliber and level of healthcare staff. Leaders for Compassionate Care Program, LCCP, is aimed to improve motivation and confidence in healthcare workers. Outcome of care. It is good to evaluate the patient's perception or perspective of what they think comes out of compassionate care. The patients themselves showed that compassionate care alleviated their suffering. It enhanced overall well-being of the patient and possibly positively enhanced augmented quality of care by allaying distress and enhancing their relationship with staff. Those who did not feel compassion had negative outcomes like frustration, being overwhelmed, and lack of dignity and hope. From the physician's point of view, compassionate physicians achieve a better understanding of their patients' issues and concerns. Compassion also helps in construction of supportive and caring treatment plans. Compassion helps physicians to cope with more challenging patient scenarios. Compassionate physicians suffered less from stress. According to Civil Treasury Compassionomics, the revolutionary scientific evidence and caring makes a difference, improves treatment adherence, speeds healing, which is very much of a concern to the surgeon, reduces unnecessary medical care. Epilogue. Can compassion be taught? Ugia described what he called compassion trichotomy, and considered the interdependence of motivation, personal reflection and values, capacity, awareness, regulation of energy, emotion, and cognition, connection, sustained patient-physician relationship. All these influence a physician's level of compassion. Outcome of training. While training is possible, at present, it is adjudged that the outcome of the training of a physician or anybody will depend on innate virtues that the trainee possesses ab initio. How do we teach compassion if compassion can be taught? The intricacies as to how and what will be required in the training program remains largely unexplored, opaque, and oblique. Barriers need to be reconceptualized as challenges that can be overcome. There is need for conceptual specificity because right now there is so much what do I say, non-specificity, such that definitions differ, contents differ. There is a growing consensus, however, that compassion is inherently relational and depends on perception. For instance, those who are familiar with geography know that the Greeks and the Cypriots are quite closely related. Most Cypriots look at compassion as empathy and kindness, while the Greek look at compassion as a deeper awareness of the suffering of others and a wish to alleviate it. So we need a consensus and a specificity. Finally, Aristotle has shown us that compassion is a feeling of pain at an apparent evil, destructive, or painful event, which befalls one who does not necessarily deserve it, and which we might expect to befall ourselves or some friends of ours. Therefore, we all need compassion, and a good surgeon should be a compassionate surgeon and give an ethical, confident, well-researched, and up-to-date, including awareness of bloodless medicine and surgery, and all that make for efficient care in a very compassionate way to our surgical patients. Thank you. Thank you for your attention.
Thank you, Professor Roland, for this great presentation. I believe that each and every one of us will be compassionate, because without compassion, we cannot move further. Definitely, we value all our patients. The patients that will fail are also the reason for our continuous improvement, because we think about what to do to prevent a recurrence. At this point in time, I want to introduce our next speaker. Our next speaker is Dr. Majid Kofa. She's the director, Institute of Patients Blood Management and Bloodless Medicine and Surgery, Eagleswood Hospital, Eagleswood. Dr. Majid Kofa specializes in the field of anesthesiology, critical care medicine, and patient blood management. She received a Doctor of Medicine degree from University of Medicine and Dentistry, Robert Wood Johnson Medical School, and subsequently completed a residency in anesthesiology. She then pursued a fellowship in critical care management at ICANN School of Medicine at Marseille, during which she developed a particular interest in patient blood management. Her research in this field has focused on optimizing blood utilization in critically ill patients, reducing unnecessary transfusion, and minimizing the risk associated with transfusion. As the medical director of the Institute for Patient Blood Management and Bloodless Medicine and Surgery at Eagleswood Health, Dr. Kofa has led numerous initiatives aimed at improving patient outcome through evidence-based blood management practice. Most recently, Dr. Kofa has created a mobile and web-based app to improve compliance for patient blood management metrics and improve efficiency of the treatment of patients for whom blood transfusion is not an option. Dr. Kaufman is dedicated to advancing the field of patient blood management, improving patient outcome, and promoting safe and effective healthcare practices. Let's make welcome Dr. Majid Kaufman as she takes us in the next topic.
Thank you so much. I really appreciate the warm welcome. Dr. Sora, thank you again for inviting me to speak this year. As for disclosures, I actually just want to be upfront with our audience that I'm not a trained bioethicist. And also, I was blessed to have joined a hospital and an institution that had kind of worked through a lot of these issues before I'd even arrived. So I want to take today to share with you what some of my thoughts are on how the Institute for Patient Blood Management and Bloodless Medicine in Inglewood have used ethics as a framework to provide exceptional patient care. And my last little disclosure is I actually worked overnight tonight. So if I switch some of my words up, I do apologize. So the concept of ethics in healthcare is actually based on the concept of this overarching concept of dignity, and that all patients are human and they have this innate right to be valued and receive ethical care and treatment. There's no ands, ifs, and buts about that. And as so many of the phenomenal speakers have spoken about this week, there are some main pillars in medical ethics. There are some people who may add more than these four, but I'm going to focus on these main four and what role they have been played in running of a patient blood management program. We're going to take actually more of a higher up view, a bit farther away from that patient-clinician relationship and focusing more on organizational ethics. So the beneficence, that's the action on focusing what is good for the patient. And then non-malfeasance, what's to avoid harm, that, the do no harm, that main concept. Autonomy, the capacity for a rational individual to make informed and uncoerced decisions. And lastly, justice, which is really concerned that there's equitable distribution of benefits and burdens to individuals within social institutions. But before we dive into the way that ethics guide a patient blood management program, I think you actually have to stop and really kind of maybe broadly define what is a PBM program. And while there might be many variations of this, needs to be some level of consistency in organizational requirements. Thankfully, SABM has created their standards, which did define a lot of requirements for a patient blood management program. So first of all, it needs to be a formal structured program. You need to identify and have the presence of clinical leaders. There has to be this, ongoing creation of policies, procedures, protocols in the area of patient blood management to ensure compliance with institutional standards. And lastly, having a defined mission and vision of these stated values to make sure that the program is continually staying on the track that it was set to do. And again, all this requires ongoing education and within multiple levels within an institution. So let's go through these ethical concepts and see how are they specific within a patient blood management program or a bloodless medicine program. So the first one, autonomy. That the patient has a right to determine what will and will not happen to them, even if this decision goes against common societal norms. I think the most common way a patient's autonomy is really protected is through informed consent process. The patient requires a truthful and complete discussion to determine what they want. Thankfully, Dr. Isbister last year in 2022 published a phenomenal paper discussing specifically the role of informed consent in patient blood management. Healthcare institutions must have a formal process to obtain informed consent. Information that's relevant to the patient must be disclosed. And this is going to be much more on a patient-specific level. So not necessarily what institution has to decide about, but there has to be this encouragement that also competence, how do you define competence, must be ensured, or the process for alternative decision makers. And in the United States, there are specific legal processes for how alternative decision makers are defined. And then comprehension also has to be confirmed, right? We have to make sure that the patient is actually understanding what they've been told. And And most importantly, voluntariness of the patient to accept or decline treatment options has to be protected within the institution. In 2022, leaders in patient blood management, many who've spoken this week and previously at BMSS, wrote the global definition of patient blood management, and specifically included was the concept of evidence-based medicine in this global definition. So what is evidence-based medicine? How's it been defined? So it's really not just solely focused on the research and evidence, or data or proof, but also has to be melded with the patient's values and preferences. So it shows how key ethical components of modern medicine and a patient blood management program must include patient engagement, shared decision-making, and informed consent. So how is this process of informed consent being done in a patient blood management program? So in our program, patients who want to enroll in our Bloodless program have to have a formal process where they receive education in their appropriate language on the educational level that helps them with their understanding. And they are able to complete documentation of what their wishes are, what their choices are. This process also can create a level of justice as well, because we are ensuring that our patients have the same conversations, consistent information, that given time to make the decisions, and they're not pressured as well. Moving on to our second ethical pillar, beneficence. An organization has to focus on doing or promoting good things for patients. I think we need to define what is good for a patient, though. It's probably best to actually use a holistic view of not just that the patient, focusing on the patient's physical well-being, but also their emotional, social, and spiritual well-beings. So how does an institution focus broadly on promoting good and making it easier to promote good for patients? An institution needs to fund and support many different areas in order to promote goodness in their patient level of care. So let's dive into some specific examples. So policies and procedures. Having a formal process that allows clinicians to know what are the expected methods of treatment, where is the evidence coming from, and what are the known risks, right? In addition, this also plays a role in justice for patients because we can ensure fair and equal treatment being offered to patients with similar health conditions. A patient still has the right to accept or decline the offered treatment, though. So some examples in our program, policies or procedures that we've included is severe anemia management when patients, have signs of end organ hypoxia or dysoxia. How do we reverse anticoagulants? What are the standards for pre-op anemia that we have defined for our institution? Culture. Building culture is not simple. Anyone in a leadership role can tell you that, hands down. And I'm the first one to admit that I was blessed to have arrived in an institution that already had a very strong culture focused on the ethical care of all patients. But specifically in our Bloodless program, this is a hospital-wide effort across all specialties. It doesn't matter if it's the dietitian, the nursing staff, the respiratory therapist, the physician at bedside, nursing. It does not exist in a silo, our commitment to the ethical care, but it's up front and center every single day. Well, ethics and money don't always come together in discussions. Healthcare institutions do have limited resources. We're all extremely aware of that. So when choosing where resources are spent, using beneficence is a very good concept to help define where resources should be provide the best for good for patients or to promote good. So just some examples in our program, if you look on the left side, these are some of the amazing people who are the dedicated staff that work in our Bloodless department who are paid to work for us. Or in the middle, an example of equipment that the hospital invests in to help us maintain cutting edge practice in areas of patient blood management. Or even lastly, this forward-focusing view. It's a screenshot of a mobile and web-based app that the hospital funded through the creation of a physician innovation grant. And this app has actually allowed us to improve our compliance with our patient blood management protocols. Also ensuring that our clinicians and our patients continue to receive education. So on the left side, we have our regularly scheduled lectures and educational sessions in so many different areas within the hospital. This is part of our functioning of our patient blood management program. And on the right, you see screenshots of some of our multiple free community educational programs that we provide in more than one language to help our patients keep up to date and educated about their own health and well-being. Moving on to our third ethical pillar, avoidance of harm. We can't avoid all harm, right? Every day we have to stick patients with needles. We give them medications that have side effects so they get dizzy or nauseous. But what are some ways an institution can continue to strive to reduce harm? We have to have research to gain more data and evidence for the role or elimination of treatments that can harm patients. We also have to have an ethical requirement to be honest and upfront with our patients when we lack data about specific areas. So what are some of the steps that programs can take to reduce harm? They need to collect data and examine it on a routine basis. They're using that internal data. They should have ongoing quality improvement projects that need to be initiated. And then when answers are challenging to find, then that means that's the areas of research that need to be further worked out. One method that we use to focus on harm reduction within the institution is our patient blood management committee. So without a strong patient blood management program, it's really hard to have a strong bloodless program. And part of our patient blood management program is this committee made up of multiple different types of clinicians, physicians, nurse practitioners, physician assistants, trainees, pharmacists. This committee is responsible for writing, reviewing, and updating protocols and policies. They consistently review data compiled by our informatics team and identify areas of improvement for our institution. Then they set up programs for improvement and evaluate the effectiveness of them. They also review specific cases where treatment really fell outside our hospital guidelines and offer ongoing education and corrective action for those clinicians. And for the last pillar, justice. A patient management program has to ensure that patients are treated justly, fairly, and equally. Discrimination has to be prohibited. So how does an institution ensure justice? Probably the main area, and there are many different types, subsections of justice, is probably procedural justice. When decisions are being made, is there a focus on dignity, right? Trust, consistency, lack of bias. And these are, when overlying decisions are being made within an institution. So when clinicians or patients, though, have a fear that there's been a lack of justice, there also needs to be a way for patients to raise this issue. So defining clear expectations for the behavior of both clinicians and patients, and also having these abilities for patients to have concerns raised. So for us in our institution, we have the Department of Patient and Family Engagement. Other institutions might have ombudsman or things like that. And lastly, the talk also wanted to encompass this concept of compassion. It can be defined as our previous speaker said, a strong feeling of sympathy for people or animals who are suffering and the desire to help them. So the first thing that I thought about when I thought about compassion was how we use language in our institution. And this is something that we work on with training our residents with the Breaking Bad, or when I do onboarding with new clinicians joining, is we really we point out and we practice some of the language that we think focusing on help that shows patients that we have this desire to help them. So, one of the examples, we really moved away from using the terms such as refuse, because it puts the patient in the light of being against the clinicians somehow. Instead, decline, which incorporates that there was thought and effort on the side of the patients, that they made a decision that they believe is best for them, and really move away from that paternalistic view to more of a patient-centered view. Another example is when a patient is severely anemic and suffering from a low hemoglobin. How do we discuss this with the patient? We've all heard that there have been horrible methods of bullying and threatening, but what if instead we continue to focus on the ethical concepts, such as autonomy? I'll say something like, you have shared that blood transfusions are not an option for you, or informed consent, right? This is a clinical point where I would be offering someone who accepted blood transfusion, right? And I give the patient the relevant information, and so that they know, beneficence, since transfusion is not an option for you, let me tell you what I can offer you, such as IV iron, erythropoietin stimulating agents, ICU admission. And then if you like to discuss other options, I give that opportunity to the patient. So I ensure justice as well. So I thought maybe to wrap it up, we'd use two examples to see how these, larger concepts apply. So a 55-year-old male is diagnosed with a large undifferentiated sarcoma involving the right kidney, parts of duodenum, jejunum. It was invading the renal vein into the IVC in the right atrium. The patient was seen at a hospital without a bloodless medicine program, and blood transfusion was not an option for the patient. And the patient was informed that they need to seek care elsewhere. Is this ethical? So autonomy, the patient has the right to decline transfusion. That was being protected and respected. Beneficence, the acknowledgement that this institution might not have the knowledge or expertise to provide good to the patient. And non-maleficence, they're not offering treatment that they're not equipped to do. So they're avoiding harm. Justice, honestly, I'm not so sure. Are they offering equal treatment? Probably yes, they're offering treatment with blood transfusions, but I actually think justice would be more appropriate if it was made that the hospital helped the patient find an accepting institution which could fully meet their needs. And then the second example, a 78-year-old on anticoagulation for atrial fibrillation and known gastric ulcer presents to the emergency department at 1 o'clock in the morning after vomiting bright red blood 3 times. She's tachycardic and has a low blood pressure, and she's seen in a hospital without a bloodless medicine program, and blood transfusion is not an option for this patient. And the patient was informed that she needs to seek care elsewhere. Is this ethical? Well, let's go through them again. Autonomy, the patient's right to decline transfusion is being respected. Beneficence, I don't think so. The good for this patient is immediate treatment to stop bleeding. Non-maleficence, that's probably not being met either, because they're causing delay in treatment for this patient by sending an unstable, actively bleeding patient to be transported to another facility. And justice, are they offering equal treatment? No. A patient with active bleeding needed to be stopped immediately. I wouldn't be remiss if I didn't always take the opportunity to thank my wonderful mentors and people who support me on every day, the ICU physicians, anesthesiologists and CRNAs, and the wonderful staff in the Bloodless Medicine Department, and of course the Patient Blood Management Committee, who I enjoy working with on a regular basis. And as always, our institute is here to help, and my email address is there. And we look forward to hearing the other speakers.
Thank you, Dr. Kaufman. At this time, I'm pleased to introduce our next speaker, Barrister Ogaga Eduru, who will deliver a lecture on medical legal issues in bloodless medicine and surgery. Ogaga Eduru is a legal practitioner, health law scholar, and researcher. He holds an LLM degree, which is master's degree in law, from Benue State University, Makurdi, Nigeria, and obtained his LLB degree, bachelor's degree, from the University of Benin, Benin City, Nigeria. He's a member of the Nigerian Bar Association with over 7 years' experience as a legal practitioner in private legal practice. He was previously a lecturer with Nasarawa State Polytechnic, Lafia, for a period of 3 years, where he taught selected law courses. As a legal scholar and researcher, he's been actively involved in research into various aspects of health law and ethics. His research interests focus on negligence, consent, mental health law, and recently on issues of consent in the medical treatment of children. I'm a pediatric hematologist, so I appreciate that. He is an author of scholarly articles in peer-reviewed journals, and notable among his works is his article entitled "The Emergence of Bloodless Medicine and Surgery in the Treatment of Patients, Medical Legal Issues Arising Therefrom."
Thank you very much for that introduction, Luis. Really appreciate it. Good day to everyone. It's happy to be among medical professionals. I feel blessed. I really feel blessed. Now, to get the ball rolling, just give me a minute. Yes, the theme for discussion for my presentation is medical legal issues in bloodless medicine and surgery. I have no disclosures. I took the time out to make an outline so that everyone will follow through. I'll just leave it up for some time. Let's say a few seconds, and then okay. Now, bloodless medicine and surgery, it's an alternate form of treatment that seeks to provide medical treatment for patients without the use of allogenic blood and blood products. Now, like every other form of treatment, bloodless medicine and surgery also has legal implications. It also has ethical duties as well as professional liabilities. Well, this presentation examines the medical legal issues arising from the use of bloodless medicine and surgery treatment, particularly issues of liability in the use of bloodless medicine and surgery, the rights of adult patients to consent to or refuse treatment with allogenic blood, and the issue of informed consent in the treatment of incapacitated patients like minors, mentally incompetent patients, and patients in emergency situations. Well, the objectives, pretty much from the introduction, we're examining the issue of liability, and we are going to explain the rights of competent adults to refuse treatment, and then identify the challenges in the use of bloodless medicine and surgery in the treatment of patients such as minors, mentally challenged patients, and patients in emergency situations. Now, we want to look at the issue of liability in the use of bloodless medicine and surgery as a form of treatment. A deviation, but before I start, I just want to bring to our notice that I made use of legal principles, and then I backed them up with statutory, mostly judicial authorities. And these authorities, judicial authorities, are taken from cases, legal cases from Nigeria and also from the UK. As much as possible, I tried to incorporate conventions that have a wider coverage, yes, like the United Nations conventions, so that everybody will be able to understand. Now, a deviation from ordinary professional practice in medicine is not necessarily an evidence of negligence. According to the justice in Hunter and Hanley, if that were to be so, it will hinder progress in medical treatment if the law were to hold otherwise. And so this therefore means that the choice of bloodless medicine and surgery as an alternative to the normal practice of blood transfusion is in itself not necessarily evidence of negligence. Now, in some cases, they've laid down some principles or tests that such alternative treatment must pass. Now, that alternative treatment or a departure from the normal practice is not negligence as long as the departure is accepted as proper by a responsible body of medical men skilled in that particular act. This means once there's a professional man, or let's say a school of thought, and medical professionals agreeing to such treatments, then the use of such treatments is not by itself negligent. The second test was laid down in Bolito and City and Hackney Health Authority, where the court held that the departure from common practice must be logical, and the court must have ensured that the experts had directed their minds to the question of comparative risks and benefits and reached a defensible conclusion on the choice of treatment. However, This doesn't mean that those who undertake bloodless medicine and surgery treatments are devoid of liabilities. And so doctors who undertake bloodless treatments would be liable in negligence if such treatments are devoid of reasonable care and skill. The previous speaker talked about consent, and then she talked about consent from the ethical point of view. But let's look at it from the legal perspective. Now, consent must be sought before proceeding with bloodless medicine and surgery treatments. Now, failure to obtain consent opens up a health care provider to battery claims. And as such, a patient can sue a doctor if the doctor does not validly obtain his consent, first had and obtained before undertaking such treatment. Now, a doctor is also under a duty to take reasonable care to ensure that the patient is aware of any material risk involved in any recommended treatment. And this would also include the alternatives present, the benefits of such treatments, as well as the outcome. But a doctor is, however, entitled to withhold from the patient such information if such information will cause risk to the patient, and also in cases of necessity where it would be impossible to obtain such consent from that patient. And that was the principle held in the Montgomery and Lanarkshire Health Board. Now, let's go over to the rights of competent adults to refuse treatment with allogenic blood. Adult patients have the right to consent to or refuse treatment with allogenic blood. It's a principle. That principle is a principle of autonomy and self-determination. And that principle is enshrined in Articles 1, 3, 12, 18, and 19 of the Universal Declaration of Human Rights. And that protects an individual's rights to dignity, to privacy, to liberty, to freedom of thoughts, conscience, religion, opinion, and expression. Those, if you look down, you also see that they are also contained in Articles 5, 8, 9, and 10 of the European Convention on Human Rights. And also these rights, as they are called fundamental rights, are also contained in the constitution of various states or countries. A patient's consent is paramount, and a medical practitioner is bound by the choice of an adult patient to refuse consent to medical treatment. No matter how weird it might seem, the medical practitioner is bound by an adult patient's decision on the form of treatment he would wish to undertake or refuse. That's contained in the case of Okonkwo and Medical and Dental Practitioners Tribunal. Now, this is where we need to give consent to. That is the use of bloodless medicine and surgery in the treatment of incompetent patients. And the first stuff we'll be discussing are minors. Now, who are minors? A child means every human being below the age of 18 years, unless under the applicable law to the child, majority is attained earlier. That's contained in Article 1 of the Convention on the Rights of the Child, 1989. What this means is, and it's almost in all countries, that the child is someone below the age of 18 years. However, countries may want to adjust the age to suit their culture or their held beliefs or so. And so that's why it says under the applicable law of the child in each country. Now, consent to medical treatment, in this case, bloodless medicine and surgery, is not solely determined by the age of a minor, but on the issue of sufficient understanding by the minor. And so we have what we call mature minors. These mature minors are eligible to consent to treatments, provided they can understand the nature and purpose of the proposed treatments and can communicate their decision. This was the holding of the courts in the case of Gillick and West Fork and Bisbee Area Health Authority. In instances where these minors are limited by their age and they cannot give consent by virtue of their age, surrogate decision makers usually make these decisions for them regarding a form of treatment. However, these decisions taken by surrogate decision makers, whether they are parents, their guardians, or a court-appointed guardian, these decisions must be taken in the best interests of the child, and it's contained in Article 3, Sub 1 of the Convention on the Rights of the Child, 1989. Now, the courts, when they are called upon to resolve disputes between parents and healthcare providers as to a particular form of treatment that is in the best interests of a child, the role of the court is to assume the powers of the parents and either give consent or withhold consent regarding a particular form of treatment. Now, the court should do this or should exercise its role in its capacity independently and objectively. Now, in considering the best interest of the child, the question for the court is whether in the best interest of the child patient, a particular decision as to the medical treatment should be taken. The term best interests, funny enough, is used in its widest sense. And so it doesn't only mean what's in the medical best interest of the child. It takes into other considerations like the emotional, the social, and the psychological factors around those cases brought before the courts. However, the court must consider the nature of the medical treatment in question, what it involves, and its prospect of success, including the likely outcome for the patient of that treatment. Now, this test is not a mathematical one. It's, as we call it in law, you have an imaginary scale where you balance the evidence of both parties. And that's what the courts do. And they try to balance all conflicting considerations in each particular case with a view to determining where the final balance lies. And if you look at that case of NHS Foundation, King's College Hospital Foundation versus Harpstrop, that was the decision of the court. Each case is fact-specific. And it turns on the particular facts of the case. And because the law cannot envisage all factors that will need to be taken into account in working a patient's best interests, it makes the best interest tests an indeterminate test because it's flexible and the court can apply it in a wide range of considerations. And this has led to different court decisions, especially in the UK. Now, some of these cases outlined there, and these cases involve decisions of the court whether to consent to life-sustaining treatment or to withhold such treatments from child patients. And so the court is called upon to determine if the hospital should withhold such treatment or should allow such treatment in the given circumstance. And the first case, the Manchester University and Verdun, there the court held that it is the least bad option to allow life-sustaining treatment to be given to the child. In the next case, Pippa Knight, the court refused or withheld its consent to continue life-sustaining treatment for the child. Life-sustaining treatment was withdrawn and the child died after. And that was the holding of the court in Alder-Hay and Gard and Evans case. But there's something new in Rakib and Bath's NHS Foundation. The court gave credence to the religious considerations of the parents, which is unheard of. And so the court said that in the absence of pain and suffering, that the treatment should be continued, taking into consideration the social and religious opinions of the parents. Now, due to this, there are other tests that have been proposed because of the indeterminate nature of the best interest test, prominent among which is the significant harm test, which is to the effect that the state will only intervene once the child protection threshold is reached, in that the child will be seen to have suffered harm or is likely to suffer harm. Now, there are alternate forms of dispute resolution between parents and healthcare providers. And this includes mediation, arbitration for moderate level disagreements. In other jurisdictions, though, disputes involving parents and healthcare providers may not be prominent because the legal system either tilts toward the opinion of parents or healthcare providers. Now, what this means is that, for example, in Nigeria, the legal system tilts towards healthcare providers, and healthcare providers can go to court to seek orders on their own to transfuse blood to a child patient. We move over to mentally incapacitated patients. Article 3 of the Convention on the Rights of Persons with Disabilities guarantees the right of mentally challenged patients to dignity, individual autonomy, including the freedom to decide what to do with their own bodies. That is the issue of informed consent. Now, this right to informed consent has received both statutory and judicial substratum. You see Section 26 of the Mental Health Act of Nigeria, Section 1 sub 5 of the Mental Capacity Act of England, and the cases of Remeda Yeta and Risi. Now, where a mentally challenged patient is unable to give consent, decision makers or donors of a lasting power of attorney are called upon to give consent on behalf of the patient, again, in his best interest. Now, that is the same whether the person is caring as a family or a relative or a guardian appointed by the court or a healthcare professional. Now, in trying to break down the considerations, section for what amounts to best interest in the case of mentally challenged patients, Section 4(6) of the Mental Capacity Act of England outlines the various considerations in reaching a best interest decision on behalf of a mentally incapacitated patient. And they are the person's past and present wishes and feelings, the person's beliefs and values, which include his religious, moral, or cultural, or political beliefs and his values that will likely influence his decision if he has capacity. Other factors that he would be likely to consider if he were able to do so. However, the problem of the best interest test still persists despite the above laid considerations. And this issue of best interest keeps coming up on and on. And there are still various different decisions. For example, if you look at the case of RB versus Brighton and Hope City Council and Aintree University Hospital NH Trust, we get these divergent decisions. Now, where patients have an advanced decision to refuse treatment, their decision should be respected, even if others think their decision to refuse treatment is not in their best interest. Finally, we looked at patients in emergency situations. An exception to the doctrine of informed consent arises when a patient is unconscious and there exists genuine emergency. The impracticability of conferring with and obtaining the consent of the patient dispenses the need for obtaining informed consent. Now, surrogate decision makers are also called upon to make decisions, and they must do so in the best interests of the patient. If a patient is in the possession of a duly executed advance directive, it is the duty of the doctor to act in accordance with the directive. And that case of Mallet and Schumann is very instructive because the doctor did not respect the advance directive. He went ahead to treat the Jehovah's Witness patient with blood, and he was held in negligence, and he had to pay damages for his conduct. Now, in conclusion, the use of bloodless medicine and surgery as a form of treatment is not in itself evidence of negligence. Consent must be sought and obtained before undertaking bloodless medicine and surgery treatments. Adult patients have the right to refuse treatment with allogenic blood. Decisions regarding choice of treatment on behalf of incompetent minors, mentally incapacitated patients, and patients in emergency situations must be taken in their best interest. The indeterminate nature of the best interest test has led to controversy and different court decisions. Thank you.
Thank you very much. At this time, I think we're able to do question and answer for the three speakers. There are some questions posted in the chat, and then others can raise their hands and try to get recognized. I think I'm looking at one question for Barrister Ediru. What is your opinion on not getting a medical guardianship and having two physicians document the need for blood transfusion?
Okay, let me see. I'm trying to get that question. Getting a medical guardianship and having two physicians document the need for blood transfusion. Oh, it depends. Like if the patient can make his consent before the procedure. Now, unless there's dispute between the guardian or the parents, if the person is a minor or is incapacitated. Now, that's the only reason where, let's say you get a medical guardianship, a court will have to appoint that person. And having two physicians document the need for a blood transfusion, it's not the physician's choice, the physician's choice to document, even if there are two or three. In cases of dispute, the court will have to decide if, okay, the person said if it's a minor. Okay, I think I just saw that. Well, if it's a minor, then, and this it's an unresolved dispute and it goes to court. It doesn't matter how many physicians thinks a blood transfusion is necessary. Now, you place the evidence before the courts, both expert evidence from the parents or the guardian, and then that of the medical team. It's left for the court to decide. So I don't think whether it's 2, 3 physicians, I don't think it's of no issue, it's of no importance. The court will decide that.
Okay. There's a follow-up question for how is the best interest determined in the case of minors?
Yes, like I said during the presentation, you have to the court has to be objective in its decision. And the court has to take into cognizance these various considerations. Now, the court will have to take in the likelihood of success of the procedures, either blood transfusion or bloodless medicine, or the bloodless medicine option. The court will then determine the likelihood of the success of the treatment and the outcome of the treatment. Now, if the court is satisfied that it's in the best interest of the minor to go ahead with blood transfusion, it will make that order. But if the court is not satisfied, then bloodless medicine treatment can also be taken. It all depends on the decision of the court.
All depends on the courts. Okay. Thank you. We have a question from Daniela Nwoko, LLB. Can you unmute yourself?
Good afternoon.
Oh, you're muted again.
Good afternoon, everyone. Can you hear me? Am I audible?
Very well, very well.
I don't have a question. I have some comments in support of Mr. Vaishnavada's presentation and in response to certain questions here. If Mr. Gada, with your kind permission, I can go ahead to make some comments. Is that all right?
Please do.
Okay, so like you have rightly mentioned, the best interest test is not a hard and fast rule. There's no hard and fast rule. It's not cast in stone. It's based on the facts presented before the court. While there's a principle that speculates what the best interest rule is, while there's a principle, it will still depend on the facts set before the court. The psychological variables, what are the alternatives to the prescribed treatment from the physician, be they one, two, or in their multiples? What are the alternatives? And then the advantage, the benefits weighed against the risk. Even when the parents are coming up with, when the reasons for the parents' objection to blood transfusion is based on religion, if they can present to the courts medical evidence that proves that bloodless medicine still supersedes blood transfusion, that will tilt the balance in favor of the patient. If there are, just like the question I'm seeing here, if there's an alternative to blood transfusion and a particular physician is insisting on blood transfusion, if it is presented to the court that there's an available alternative physician willing and ready to subscribe to the preferred treatment of the patient, it is very likely that the court will tilt to giving the patient, being the minor, the opportunity to seek a preferred treatment. Take, for example, certain individuals go to the hospital with an already prepared DND, do not resuscitate. Even if the physician feels that, oh, if I resuscitate this person, he has the ability to live 1,000 more years, that documentation already ties the hand of the physician from doing anything, even though it's in the best interest of the patient. So it is, as he has said, based on the facts set before the court. Unfortunately, in our judicial system in Nigeria, the court is already tilted in the side of the medical practitioners. And just as Joanne mentioned in the beginning, we need to keep learning. The problem we have in our system is that our judges are ignorant of the advancement in medical health, especially with respect to bloodless medicine. And most of our medical practitioners are stuck in the age-old practice of blood transfusion. Some of them don't even want to bring that option to the knowledge of their patient. They just want to have the easy transfuse the blood and let us go on with it. The idea of presenting the option of alternative to blood transfusion is as a last resort for them. So patients are now encouraged to make their own research. Sometimes it is the patient who will bring it to the knowledge of the medical practitioner. Oh, what if I do this? What if I take this route? What if I take this option? And then you will see some of them reluctantly agree. And while others will be, oh, that is an option you can subscribe to. So seminars like these are things that can also help both the medical practitioners and our judicial system to grow. Thank you very much for the opportunity.
Thank you very much for that addition. It was succinct. It was really explained. Thank you. If I may just add this, it's time for our judicial system, especially in Nigeria, to wake up and to see to be objective in its decision. Yes, for a fact, doctors here do not know much about bloodless medicine and treatment. They've not even researched about it. People don't even know. The courts do not know. While it is good practice for them to refer to centers where these treatments can be done, but because of their ignorance, they don't know and they insist on blood transfusion. And they go to court using ex parte applications. They just go to seek an order without even hearing from the parents of the child, without presenting expert witness. The court makes decision to transfuse blood. And this is unacceptable, especially in the 21st century. So it's an ongoing battle, and we hope people will be educated and see the need for bloodless medicine as an advantageous and as a better form of treatment than blood transfusion.
All right. Thank you so much for the discussion. There are so many more things to talk about, and there are probably 4 more questions in the chat that we will have to have for written answers. I think we need to conclude the session in order to keep the rest of the whole symposium on time. Thank you, all the speakers, so much. And Dr. Osoro, do we just conclude at this point? And do you also, there was also a question about whether this will be available as recording.
Oh, certainly, it's going to be available. Right now, it's online because there's a live stream. Just before you move on, I think there is here with us Dr. Basi Ndomaiba. Is his video on? Okay, could you turn on your video, please? We are sort of very happy to have him here because he's a fellow of the Royal College like his dad. His dad made the first presentation for the day. So welcome. You want to make some comments, Basi?
Thank you very much for inviting me on. I've had very beneficial 2 days learning about these issues that are facing the bloodless movement, bloodless medicine and surgery. I just want to say that in terms of the subject matter of the whole meeting, in terms of compassion, I think it's the way forward, and I just want to commend the organizer of this meeting for addressing this very topical issue. I think that also in my jurisdiction, compassion training is part of human factors training, which is essential for all residents to be aware of the implications of what we do and also the benefits of addressing this issue with our patients. So thank you again very much to everybody, and I have to commend the quality and the topics of the speakers so far. I found it very interesting. I look forward to the rest of the meeting. Thank you.
Thank you, Basi. So, Dr. Sue, do you want to call the next moderators?
Yes, thank you. So we are moving to the moderators for the next session, Symposium on Bloodless Surgery Techniques, Dr. Tomi Ayewu and Richard Verstraete, RN. I'm sorry if I mispronounced your names.
That's okay.
kind of.
Good evening, Madam Administrator.
Welcome everyone to this. Am I audible?
Very much so. Yes.
I'd like to welcome all to this symposium session of the conference on bloodless surgery. My name is Oluwatomi Oyewo. I'm a urologist at the General Hospital in Ikorodu. My co-author is Richard Versus-Che. Apologies for the pronunciation, sir. Who is the nurse coordinator, Bloodless Medicine and Surgery Program of MedStar, Georgetown University Hospital in Washington, D.C. Over to you, Sir Richard.
Hello, how are you?
Thank you.
Thank you. You want me to get started? Okay. So I'm very excited to be here. Welcome to all the participants. So we're going to get started. I'm going to introduce Dr. Linda Shore-Lesserson, and her topic is preoperative interventions for successful bloodless cardiac surgery. Dr. Shore-Lesserson is a professor of anesthesiology at Zucker School of Medicine at Hospital Northwell. She's vice chair of academic affairs and director of cardiothoracic anesthesiology at North Shore University Hospital. Dr. Shore-Lesserson, received her medical degree from the University of Pennsylvania. After doing her anesthesia residency, she spent a specialty year in cardiothoracic anesthesia fellowship at Mount Sinai School of Medicine in New York. She is a diplomat with the American Board of Anesthesiology and the National Board of Echocardiography. Her clinical and academic anesthesiologist is past president of Society for Cardiovascular Anesthesiologists and currently serves on the board of directors of the National Board of Echocardiography. As an educator, she has been program chair for numerous national meetings and is currently the general chair of the New York Society of Anesthesiologists and their PGA annual meeting. She is the third vice chair of the Anesthesiology Association of Anesthesiologists annual meeting oversight committee, and she is a fellow of the American Heart Association and assumed the chair this year of the Surgery and Anesthesia Council of the American Heart Association over multidisciplinary positions, includes being anesthesiologist lead, working with the Society for Thoracic Surgeon and the American Society of Extracorporeal Technology, and working on a project called Best Practices in Perfusion Management. She is past chair of the Patient Blood Management for the American Association of Anesthesiologists and is currently the president-elect for SABM. Her research interest is in the field of hemostasis and thrombosis as it relates to cardiovascular surgery. She's published in many high-impact peer-reviewed journals and is a frequent lecturer at national and international scientific meetings. Welcome, Dr. Shore-Lesserson.
Well, thank you very much. Thank you, Mr. Verstrate and Dr. Tomi. It's really an honor and a pleasure to be here with you. Congratulations to Dr. Usoro for such a fantastic, well-attended meeting of the Bloodless Medicine and Surgery Society. It's really an honor for me to be here to speak with you. I'm going to bring up my screen, which I think we can see now. And what I'd like to do is give you a few disclosures. And unlike most other of our speakers this morning, I will not be approaching this topic from a compassion standpoint, but I think that's okay because we all understand the importance of compassion and ethics in the practice of bloodless medicine and surgery. My disclosures are not relevant to any industry affiliations, but the one disclosure I have is that I am, as was mentioned by Mr. Verstraete, president-elect of SABM. And so I'm going to approach this topic from a patient blood management perspective. All morning long and yesterday, we heard wonderful discussions about bloodless medicine, or the patient for whom blood is not an option. But in order to practice bloodless medicine, you really need to have a program that informs all of the facets of patient blood management. So these 4 tenets of patient blood management are really critical, and they build the foundation of a bloodless medicine and surgery program. So what I would like to do is take these 3 or 4 tenets of PBM and apply them to cardiac surgery and talk about how we can practice nearly bloodless or bloodless surgery in cardiac surgery patients by practicing patient blood management. This is the guideline that was published last year, actually early this year, and you can see that it was multidisciplinary and it was endorsed by multiple societies: Society for Thoracic Surgeons, Society of Cardiovascular Anesthesiologists, AMSECT, which is the Perfusionist Society, American Society of Extracorporeal Technology. And we talked yesterday about what a perfusionist does and how they contribute to PBM, and SABM, our patient blood management organization. And what I would like to focus on are the interdisciplinary measures, the management of anemia, and optimizing coagulation, because I believe we have done a very good service already this morning to the patient empowerment and patient autonomy aspects of bloodless medicine. So we all know the definition that was published by the World Health Organization, that patient blood management is patient-centered, it's systematic, and it's meant to improve outcomes by practicing optimal techniques and by patient empowerment. So how do we practice PBM in cardiac surgery? It's used to be felt that patient blood management couldn't be practiced in cardiac surgery patients because they are so critical and they're so acutely ill, and their surgeries often cannot be scheduled in advance. And while some of these things are true, it does not preclude the practice of PBM. So we're going to discuss anemia management, preserving coagulation by pharmacologic and technologic means, the use of transfusion algorithms and different transfusion strategies. So as I mentioned, patient blood management does incorporate the practice of transfusion, albeit to a very minimal degree. And we can take lessons from patient blood management to practice bloodless medicine. And then finally, there are techniques we can use to minimize blood loss and hemodilution that are really practiced by the perfusionists. And so they're a very critical part of patient blood management in the cardiac surgery operating suite. Anemia management, let's talk about that first. So in the guideline that you saw published by STS, anemia management and the use of erythropoietin is a class 2A recommendation. So it is recommended, it is suggested, and I will mention that the European cardiothoracic guideline gives erythropoietin a class 1. So there are a lot of differences of opinion as to how important and critical the use of erythropoietic agents before cardiac surgery are. So here's one study that was published by you and colleagues a number of years ago. It was a randomized control study in valvular patients, and patients were given a treatment, a single treatment, 16 to 24 hours before surgery that included IV iron and erythropoietin, and they were compared to a placebo group. The endpoints were transfusions and reticulocyte counts and iron profiles. And what they found in the days following surgery was that there was very little difference in the hemoglobin values between these two groups. Now, keep in mind, this was a single dose treatment the day before surgery. So we don't see immediate response in the postoperative 7 days. In fact, at postoperative day 7, there were no differences between these two groups, treatment and control. But if you look at the reticulocyte counts, the patients who received iron and erythropoietin had a significantly higher reticulocyte response, which probably means that after they went home, they continued to retic and to build red blood cell mass better than a different or a control group. So these are patients who were probably feeling better and recovering better after cardiac surgery. An important but small study to keep in mind. If we look at another study, and if you look at the results of transfusion of these groups, you can see that there was a statistical difference in the red blood cell units that was transfused in the EPO group versus control. And you can also see that significantly fewer percentage of patients were transfused in the study group. So we did save on transfusions. We may not have seen a difference in hemoglobin, but we also saw a difference in the reticulocyte response, especially as the patients were discharged from the hospital. Now, if we look at another study by Professor Donat Spahn and colleagues, where he performed a small, about 60 patient randomized controlled trial, CABG and or valve patients, and his treatment was also a single treatment 24 hours prior to surgery. The patients enrolled were iron deficient or anemic. And the placebo group was our control group, and the study group received a cocktail of iron, erythropoietin, B12, and folic acid. Now, this was a costly endeavor, and that is why I show you the cost in Swiss francs and euros, because the erythropoietin was a costly endeavor here. So let's look at what the results show us. You can see that the red blood cells transfused were significantly lower in the treated patients. Up to 90 days after surgery, they received fewer red blood cells. The red blood cell acquisition costs were also significantly lower, but when they took into consideration the total acquisition costs and included the pharmacologic agent, there was an increase in cost in the treated group. So this is important to consider. Anemia management can be performed over a longer period of time without erythropoietics. Erythropoietics have come down in price since this intervention. So important to consider all aspects of the treatment before embarking upon a preoperative management strategy. Now, we can't leave anemia management until we do talk about restrictive versus liberal strategies. And this is where patient blood management and perhaps bloodless practice do diverge. So David Mazur and colleagues studied in their TRIX-3 trial a restrictive versus liberal red blood cell transfusion strategy. And they randomized patients to either a 7.5 hemoglobin or a 9.5 hemoglobin threshold. The primary outcome was a composite outcome of all of these adverse events: death, MI, stroke, acute renal failure. And what they found was that whether you were randomized to a restrictive or a liberal arm, there were no differences in these adverse outcomes in the composite. So the primary outcome was the same. What they did notice was that the restrictive transfusion group was transfused less, 52% of the time versus almost 73% of the time. So you can have a similar outcome and transfuse fewer red blood cells, and that seems to be ideal. That study is moving forward because it turns out that the restrictive group, the restrictive practice of red blood cell transfusion was seen to only be beneficial in an elderly patient cohort, patients older than 75 years of age. So whether or not this was a statistical confounder or whether or not it was an actual effect of restrictive transfusion only applying in a sub-cohort of patients, we're now awaiting the results of TRIX-4, which was set out to investigate that very question as to whether or not there was an age differential in the practice of restrictive transfusion medicine. Now we move on to the coagulation aspects. And these are perhaps the toughest because cardiac surgery patients have a lot of coagulation disturbances. Many of them start with coagulation impairment because they're on pharmacology, antiplatelet drugs, anticoagulant drugs. And then during surgery, they are certainly exposed to coagulation defects by high-dose heparin, platelet consumption, fibrinolysis, coagulation factor depletion, hemodilution, and all of these other things. So this is a really ripe area for research in cardiac surgery. So we start out by looking at the coagulation cascades that are activated whenever patients are placed on extracorporeal circulation. And these are the well-known coagulation pathways that form thrombin and fibrin and are caused by activation due to the extracorporeal circuit. So what we do is we use antifibrinolytic agents as lysine analog inhibitors. So lysine analogs will bind to plasmin and inhibit them from acting. And this is how antifibrinolytic agents work. The original antifibrinolytic agents we used were protease inhibitors. Those are not used so much anymore because of some adverse effects that were appreciated. And now our practice is pretty much exclusively limited to the synthetic antifibrinolytic agents, tranexamic acid being the most prevalent in the world, and epsilon aminocaproic acid also being used in the United States. So where is the evidence for the use of antifibrinolytic agents? There are, I would dare say, thousands of studies, certainly hundreds of randomized studies, and thousands of other studies looking at the effects of tranexamic acid in cardiac surgery. So I'll call your attention to a single study that I think highlights these effects very well. The Atticus trial was a multi-center, 7-country, 31 sites, randomized prospective trial by Paul Miles and colleagues. And in nearly 5,000 patients, they randomized to tranexamic acid or placebo. Initially, they started with a relatively large dose of tranexamic acid. This is much larger than what is now utilized in clinical practice. They dropped down to 50 milligrams per kilo and identified that their 2 randomization groups were demographically similar. And if you look at the results of transfusions and of adverse outcomes, you can see that the adverse outcomes were not different in the tranexamic acid or placebo group. The reason we look carefully at these adverse outcomes, aside from the intuitive need to know, is that as an antifibrinolytic, there's theoretical concern for thrombosis. It turns out that these agents really are not prothrombotic. And as you can see here, any thrombotic outcomes were completely not different between these 2 groups. If you look at the bleeding outcomes, you can see that there were statistical differences. There was fewer reoperations, fewer total products transfused, fewer hours spent on mechanical ventilation, and a statistically increased incidence of seizures, which was unfortunate and only seen when that large dose of tranexamic acid, 100 milligram per kilo, was given. Dropping down to the half dose and even lower doses, which are used throughout the world, this seizure disorder has not been confirmed in any sort of mechanistic or randomized controlled trial. So needless to say, tranexamic acid, antifibrinolytic therapy, has maintained its place in cardiac surgery as a class 1 recommended anti-bleeding provocative agent. We are pretty much using ubiquitously these agents unless there's an overt contraindication. Another topic that the cardiac surgery guideline focuses on is medication cessation, because as I mentioned, many of our patients are presenting on these antiplatelet agents. And so a class 1 recommendation was given to this recommendation. In order to reduce bleeding, patients on antiplatelet agents, if it's ticagrelor, should be stopped for 3 days. If it is clopidogrel, should be stopped for 5 days, and prasugrel, should be stopped for 7 days. And this is pretty well accepted throughout different organizations that make recommendations for medication cessation. So we need to approach these patients from all different angles. We cause them to be coagulopathic by pharmacology and by what we do to them during cardiac surgery. Moving on in how we can practice PBM and somewhat of bloodless care in cardiac surgery are the use of transfusion algorithms and strategies. So transfusion algorithms don't have to incorporate transfusion. And that's where they may be misnamed, and that is where they can be used in bloodless medicine and surgery for cardiac patients. So this is a blank algorithm, and what you might imagine is that some practices are using allogeneic blood products in this algorithm, but we're also adopting pharmacologic agents like prothrombin complex concentrates rather than plasma, or fibrinogen concentrates rather than cryoprecipitate. And certainly the red blood cell arm has a lot of different nuances whereby that can be addressed using bloodless medicine techniques. So this is a class 1 recommendation in the current guideline, and it states goal-directed transfusion algorithms which incorporate point-of-care testing, such as with viscoelastic tests, are recommended to reduce peri-procedural bleeding. And what I've shown here are a few of the very common and popular viscoelastic tests. You may not be restricted to viscoelastic. Notice it says such as. So centers that aren't fortunate enough to have viscoelastic testing, we can still practice algorithmic treatment without these devices, with laboratory treatment, or with just a rational approach to what are the most likely defects that cardiac surgery patients are likely to experience after extracorporeal circulation. So we see the different devices here. Many of them are now cartridge-based, so they're easy to use and much better accepted by laboratories that don't have a lot of manpower to conduct a lot of specific testing environments. And this is also a very busy slide and not meant to be focused on in any particular area. What I'd like to emphasize with this slide is that it doesn't matter what your algorithm is. You can use one algorithm using one test, or another algorithm using another test. Newer tests also have algorithms. Some of them are graded in that the response to the defect measured is increased based on the magnitude of abnormality of the testing result, 1, 2, or 4 units of plasma, for example. And so your algorithm that you choose really depends on where you practice, what your hospital or health system is able to afford, will be willing to spend on, and the logical consequence of what's likely to be abnormal. So just to summarize the literature on transfusion algorithms, one meta-analysis I bring to you, and there are many, there are probably a handful of meta-analyses, and as I mentioned, hundreds of controlled trials as well. So Lodekes and colleagues studied 8,000 patients in studies that were both observational and randomized controlled trials. And looking at the cohort here of randomized studies, you can see that when comparing viscoelastic algorithm treatment to standard laboratory treatment, which was the control group, there's a significant balance in favor of less red blood cell transfusion using point-of-care testing. Similarly, if you look at the results with plasma transfusion, you can also see that there was a benefit to point-of-care testing versus laboratory-based control, and same results were shown with platelet transfusion. So all of our allogeneic blood products, if we do choose to use them in a certain patient population, are reduced when you use a logical, rational, algorithmic approach using one of these point-of-care tests. Now we're going to move on to the final aspect of patient blood management in cardiac surgery patients, and that's the minimization of hemodilution. The reason this is so unique is because we have this group of clinicians and professionals, the perfusionists, that run the heart-lung machine, and how they practice really impacts blood outcomes. Now, hemodilution has been known to reduce coagulation factor levels, to reduce platelet count, and to cause bleeding by a result of those factors. So we are trying to exercise techniques that minimize hemodilution. Some of them minimize hemodilution by not allowing it to occur, Others minimize it by allowing it to occur, but then performing acts like hemofiltration and ultrafiltration to then remove the extra plasma that was introduced into the circulation. So when and how you practice the minimization of hemodilution is really your practice's preference. These techniques that you see here stand for autologous normovolemic hemodilution. That actually is before the surgery takes place, minimizing the hemodilution that we get by sequestering some blood prior to surgery. And this is accepted for most patients in bloodless practice. MUF stands for modified ultrafiltration. This is a filtration that takes place at the end of cardiopulmonary bypass that removes the clear ultrafiltrate and maintains a higher hemoglobin level. Hemofiltration is done during bypass, and CS stands for cell salvage, which is another very commonly used and well-accepted strategy. So these are the class 1, I'll call them technology recommendations from the guideline. Reducing the priming volume, as we talked about, minimizing hemodilution. We take a priming volume that's often 800 cc's to a liter in the cardiopulmonary bypass circuit, and you add that to a patient's circulation. That's a significant hemodilution. So there are techniques we can use that reduce that. And we'll talk about what they are in a second. But those are a class 1 recommendation to minimize hemodilution. Similarly, the use of cell salvage, which is not new and not new to cardiac surgery guidelines, is also a class 1 recommendation. So these are the ways we can limit hemodilution. We can use mini circuitry, ultrafiltration, which I have just briefly described, and retrograde autologous prime. So we'll talk about these as we get to some of the studies that highlight their efficacy. Mini circuitry is the adoption of a combined strategy to the surgical approach where perfusion management minimizes the size of the circuit, so there's a smaller ultrafiltrate volume added to the circulation. And it also uses biocompatible surfaces, so surfaces lined with either heparin-like substances or others that reduce the inflammatory response to cardiopulmonary bypass. And this is termed MIECC, or minimally invasive extracorporeal circulation. It's really unclear whether or not MICC works because it really reduces the inflammatory response. But it does reduce hemodilution because we have a smaller volume that's added to the circulation. So here is one meta-analysis of a number of studies in CABG and in aortic valve patients looking at the effects of minimally invasive circulation, MIECC, to a control group who had standard extracorporeal circulation. And you can see that all of these groups of patients, whether it be CABG or valve surgery, had a statistically significant benefit when it came to red blood cell transfusion when minimally invasive circulation was used. As I mentioned, these studies have some bias. If you look at the strength of these studies, they would appear to have a high bias value. And it's not clear whether or not this reduction in transfusion of about 17% of patients transfused with minimally invasive surgeries or minimally invasive circuits, versus 43% in the control group. It's not clear if this was due to the minimization of hemodilution. So let's keep that in mind when we look at the minimization of hemodilution. This is not meant to be a reduction in inflammation. This is just a reduction in the priming volume. So this was a very large study. 47,000 patients were evaluated in the SCOPE registry. These were all CABG patients, and the volume of the prime was looked at as a normalization to the blood volume of the patient. So this was a ratio, a prime volume ratio, which we'll refer to as PV. And a number of different confounding variables were evaluated for the risk of blood transfusion. These were patient gender, size, length of surgery, and also ejection fraction and disease state prior to surgery. And these were all looked at in a multivariate analysis And it was determined that their primary outcome would be the transfusion of either 1 or more units or 4 or more units of red blood cells. And what was found was that the smallest, or the no transfusion group, ended up with the smallest prime volume ratio. So this was 16%, meaning that 16% of the blood volume, if the blood volume was 5 liters, 16% of that, whether it be some 200, 300 milliliters, that small prime volume was actually found in the zero transfusion group. And the other groups that were transfused all had similar prime volume ratios. So it was determined that a prime volume should be about 16% of the patient's blood volume. And if you look at the visual plot that was calculated based on the probability of getting a transfusion, you can see that the smallest probability of getting a transfusion being on the y-axis, the model-adjusted smallest risk of getting a transfusion was at a prime volume of about 15 or 16%. But this was only true in the patients whose starting hematocrit was 32. This graph here was the patients whose starting hematocrit was 40. So prime volume may not have as much of an impact in patients whose hemoglobin level is maintained initially prior to surgery. And you can also see that when you look at the risk of receiving 4 units, that once you get to a prime volume of about 15%, it doesn't really matter if your hematocrit is 32 or 40. If you're looking at a 4-unit transfusion, prime volume has very little impact. Now, the other methods of ultrafiltration are also very useful to reduce hemodilution. And by taking off clear fluid by either ultrafiltration or modified ultrafiltration or zero balanced ultrafiltration, we boost our hematocrit value, right? So by taking off clear fluid by any of a number of these techniques, you can reduce the red blood cell need. And these studies are all different types of ultrafiltration, utilized in randomized or observational fashion. And what we find with these studies was that there was a savings of 0.73 units per patient in blood transfusion when ultrafiltration or modified ultrafiltration was used. And these are very strong, very well-balanced studies. And most of these are randomized controlled trials. Moving on to the final technique is retrograde autologous prime. This is RAP, stands for retrograde autologous prime. And what this is the removal of autologous blood into the circuit to displace the clear fluid in the circuit before the patient is even placed on extracorporeal circulation. So in a sense, we're really priming the circuit with the patient's own blood instead of clear fluid. And this is obviously a minimization of hemodilution technique. And in this nice meta-analysis done by Nadja Hensley at the Johns Hopkins, we can see that in 8 observational and 10 randomized controlled trials, that the use of retrograde autologous prime was very significantly beneficial. And it resulted in an overall odds ratio of 0.34, a significant savings of risk of transfusion when retrograde autologous prime is used. Needless to say, all of these techniques can't be used together because you would really remove the entire blood volume from the patient if you used RAP and hemodilution and minimally invasive techniques and preoperative autologous normovolemic hemodilution. So the techniques that are used by any particular practice are really preference. But needless to say, it should be known that minimizing hemodilution by whatever combination of techniques is preferable is an important concept of blood conservation in cardiac surgery, most of which achieve a Class 1 recommendation. So in summary, bloodless cardiac surgery requires the use of patient blood management. And patient blood management informed all of the recommendations that were demonstrated in that guideline. Stresses the importance of a multimodal, multidisciplinary approach to preserve red blood cells, coagulation, and circuit modifications by the perfusionists for all of these cardiac surgery patients who are at high risk for transfusion. So I want to thank again the organizers and moderators of this session. I will put in one plug for the next SABM meeting, which is in Phoenix, Arizona, September 12th through 14th of next year. I'd love to see this group of passionate, bloodless practitioners there at the SABM meeting. Thank you very much for your attention.
Thank you. Thank you very much, Dr. Linda. Beautiful presentation. Please, I'd like to invite Dr. Kelly Johnson-Abel. You are there to please give us your presentation. Kelly, please. Kelly.
Please, could you read her citation?
Yeah, I'm afraid I don't have that.
Wow. Okay, so maybe Richard can do that. Dick?
Help me, please. Thank you very much.
Yes. So Dr. Johnson-Arbor is going to talk about compassion and anemia. This is a very exciting topic. I'm good friends with Dr. Johnson-Arbor, and we've collaborated on a lot of things with our bloodless patients. So I'm very happy to introduce Dr. Kelly Johnson-Arbor.
Okay, now can you hear me okay?
Yeah, we can hear you.
Great. Okay. So I'm just going to bring my slides back up. Perfect. So, and you can see my screen. So we're going to talk back more about ethical aspects of compassion and bloodless medicine today. And in this talk, I'm going to go into it a little bit more of a historical perspective. So again, thank you to the organizers and Dr. Osoro and the moderators. This is such a great meeting. This took me in a little bit of a different direction than I thought that I'm used to going in. So I am definitely not an ethics expert, but I wanted to present a little bit about ethics and the historical aspects of it today. Additionally, I do want to say that the principles discussed in this talk are reflective of the experience in the US, but certainly may have relevance to other countries as well. So we are going to do a few things today. We'll talk about the definition of compassion in healthcare. I know that we've gone over this multiple times in this meeting, so I'll just give a different perspective. We'll name some concepts that are in the Hippocratic model of ethics. We'll talk about some principles of informed consent. And finally, we'll discuss some potential limitations of informed consent in bloodless medicine patients. So I'm going to start with a quick case. So this is a case that Dick and I actually had maybe about a year ago. So we had a 70-year-old man who was a Jehovah's Witness who underwent a deceased donor kidney transplant. And then a couple of years later, he developed some pretty severe and progressive anemia. So he initially did not come to our hospital. He was referred to a hematologist at a very well-known academic tertiary care medical center. And the hematologist recommended that he undergo outpatient iron infusions. So he did that, but despite those treatments, his hemoglobin kept going down. His hematologist basically referred him for palliative care and said that there's no other treatment options available. So the patient took it upon himself to move across several states, and he showed up in our hospital once his hemoglobin dropped down to 2.8. He was admitted to our facility. Upon admission, he was lethargic. He was slow to answer questions, which is to be expected with a hemoglobin concentration that low. And his hemoglobin actually dropped to 2.2 a couple of days after admission. He looked really, really bad. Dick saw him, ordered some labs, and his labs were consistent with iron deficiency. And so Dick recommended treatment with high dose EPO as well as additional doses of sodium ferric gluconate. I'm the hyperbaric medicine physician here at the hospital, so I was involved because the patient was also referred for hyperbaric medicine evaluation. We were really not able to put him in the hyperbaric chamber initially because he was so altered and so confused, and he really did not have the ability to consent for hyperbarics, and he didn't have any family members around with him because, again, he is from out of state. So he ended up just getting EPO and IV iron, and 11 days after admission, his hemoglobin went up to 3. By that time, his mental status was actually a lot better, and we were able to get him into the hyperbaric chamber, which was great. Once his hemoglobin hit 5.6, he said that he felt better than ever. He was walking the halls, and he said that he was ready to go home. But luckily, we convinced him to stay until his hemoglobin improved a little further. So after 3.5 weeks of hospitalization here, his hemoglobin reached 6.9, and he was able to go home, and he did great. So this is just an example of a case that could have gone really badly, but it didn't for a couple of reasons. And I wanted to talk about some of the thought processes in this case from the initial interventions towards the end of the treatment, and how we as humans go through these thought processes and come to our conclusions. So I'm going to start off by talking about facts and values and norms. So facts are indisputable terms. So the sky is blue, right? That is a fact. You cannot, unless you have some other visual disturbance, you're not going to be able to prove that the sky is not blue. Values, however, are beliefs that motivate our decision choices and clinical practices. So this is really important because values are subjective. So I might value politeness, and that value of politeness is going to help me decide how to behave. And those behaviors or standards are the accepted norms that we typically follow. So the value of politeness might translate into a norm of, saying hi to people in the hallway and saying please and thank you. But again, it's important to remember that the values are very subjective. And so what is something that I value might be different than a value that you may express. All right, so in this case, it's definitely a fact that the patient had severe anemia. His hemoglobin was 2.2. So we have an objective measurement of anemia that was severe. That is a fact. We cannot dispute that. But where do we go from there? So in anemic patients, the value that we hold as physicians and medical professionals to do no harm often translate into the widely accepted norm of giving blood products. So it's a value to do no harm. What does that mean, though? So doing no harm can mean different things from one person to another. And this is where some of the problems come up and some of the misconceptions and misunderstandings about the treatment of bloodless medicine patients all may derive from this value of doing no harm. And the way that we perceive healing as physicians can differ from the way that patients perceive healing. Now, we all agree that healing is important, but the ways that we go about the healing process do not always remain convergent. They may certainly diverge. So this is where compassion comes in. So we've heard a lot of different definitions of compassion in the last couple of days. I'm going to enter with another definition of compassion, and this is more of a healthcare-based definition of compassion. So Dr. Edmund Pellegrino was a very famous ethicist who actually ran the Ethics Center here at Georgetown University for many years. And he wrote maybe like 600 or so articles about ethics. And in one of those articles, he defines compassion. So Dr. Pellegrino's definition of compassion includes the statement, the patient must enter the predicament of the patient, or the physician must enter the predicament of the patient to feel something of the patient's plight if his or her scientific judgments are to be a morally defensible and suited to the life of a particular patient. So again, this means that as healthcare professionals, we need to really enter our patient's predicament and understand what the patient is going through. Sounds pretty easy, but I don't think that we do a great job of doing this in clinical practice. So here's a couple of cases, and I'm sure that you guys are all familiar with these, but there was a 1991 survey of critical care physicians in Europe. And in that survey, 63% of the physicians said that they would order blood for a Jehovah's Witness patient who is exsanguinating, even if that patient had previously expressed a desire to avoid transfusion. So this is an older article. It's from the 1990s. Maybe it's not as relevant to how we practice today. Or maybe it is, because just over 10 years ago, in 2010, a physician in Italy ordered a transfusion for a patient who had previously declined to receive blood products. And that physician was subsequently charged with assault and convicted at trial. So even knowing the definition of compassion, and I think most of us think that we are compassionate people, somehow we are not conveying that in our clinical practice because we are not getting into the patient's values and the patient's mindset, and we are still doing things like administering blood products to patients who decline them. Why do we do that? So in the US, at least, and I think this is also true worldwide, the Jehovah's Witness patients carry these advanced directives. Now, what's interesting and what I recently learned is that these are state specific in the US. So the language that is included on the directives is specific for the particular state code. Here I have codes for both Virginia and the District of Columbia, and you can see that the cards are a little bit different. So the very top of the card, the title is different. In Virginia, it's an advanced directive. In the District of Columbia, it's a durable power of attorney. The small print below the title lists the specific code of law in the particular jurisdiction that provides relevance for the document, and the language is a little bit different too. So these, and again, we all know this, these are legal documents. These are not documents that are just drawn up haphazardly by the Jehovah's Witness population, but they're legal documents. So why do we not follow them? Why do we still attempt to transfuse patients, and why do we still transfuse patients who decline to receive blood products? So to answer this, I looked into why we might not be compassionate. And this is a really difficult topic to discuss. And interestingly, there's not a lot about it in medical literature written by physicians. It's mostly in the nursing literature. So why do we lose compassion in healthcare? And this has been discussed previously during this talk, so I'll go through it pretty quickly. Number one, if we don't have support from our colleagues. So if you don't have a collegial team that you work with, you might not feel as attached to your job and to your position. If you don't have support from your hospital administration, you're going to likely feel burnt out and lose compassion. If you don't really understand what you're doing at work, if your work sort of lacks a purpose because you don't have adequate information about your particular duties, you can lose compassion. And then, and I think this is one of the most important ones, if you have a stressful work environment, that has been shown to decrease compassion. So stress is important. When I talk to the HLC, the local HLC representatives in my area, they tell me that they like to meet with doctors and nurses and healthcare professionals in calm situations, because when people are under stress, they tend to not want to engage and learn about bloodless medicine. It's much more difficult to convey these bloodless medicine discussions to physicians and nurses and other professionals when they are under stress, when the patient has a critically low hemoglobin and is in the ICU. So what happens when we're stressed? When we are stressed in the hospital, we don't really have the time to take to read the literature, to discuss it with our colleagues. We have a lot of fear. We fear that we're going to lose the patient. We fear that we're going to fail either ourselves or the hospital or the patient. And once again, we fear that we're going to cause harm. So again, this concept of doing no harm is so pervasive in our medical culture. When we are stressed, the fear of causing harm is going to make us lose compassion. And that's really important. So now I'm going to talk a little bit about the historical aspects of this, where this concept of doing no harm is so important to us. And it's mentioned over and over again, since the beginning of our first year of medical school. So where does this come from? So back in the 400 BC area, Hippocrates was in Greece. He was a Greek ethicist, and he authored a bunch of manuscripts on a variety of medical topics. And he was the first to really identify the principles of ethics in medicine and to identify the importance of protecting the interest of the patient. So he wrote the Hippocratic Oath. That was one of his documents. And that is where the first mention comes in of doing no harm. So where does this come from? So back in ancient Greece, anybody could be a doctor. You did not have to go to medical school. You did not have to have specific training. Anybody could do it. And so the Hippocratic Oath was likely crafted in order to draft some sort of a moral code for those who called themselves physicians. Because again, you could be a charlatan, you could be a quack doctor, and you could be selling snake oil, and you could still call yourself a physician. So Hippocrates came out and laid down these basic principles of ethics so that the trained doctors, as well as the charlatans, could practice medicine in an ethical perspective. So the oath that Hippocrates wrote was meant to exist as like a swearing-in document for new physicians. And it's still administered today, although it certainly has been modified by some institutions. It's administered as an introductory oath for students who are starting to engage in the practice of medicine. So the Hippocratic Oath defines morals for medical behavior. It talks about these principles that we've heard about so much during this meeting, beneficence, non-maleficence, and confidentiality. I will go through these very quickly in the interest of time, as they've already been discussed, but beneficence is the concept of doing good to others that is tied in very closely with the concept of non-maleficence, which is where we find that concept of doing no harm that we keep coming back to over and over again. And then there's confidentiality, which is the act of protecting our personal information of our patients. And again, before I go to the next slide, again, these are very basic concepts. And again, they were initially defined in the context of how anybody could practice medicine. So, you know, it was really just a very basic thing, like do not sell snake oil, make sure that your treatments, even if they are not backed by any science, make sure that they do no harm. And again, we interpret that again today. So unfortunately, the concepts of beneficence and non-maleficence are not always indicative of an equal patient-physician relationship as Hippocrates envisioned. So there's been a lot of critics of the Hippocratic Oath. Some of them note that the oath actually promotes paternalism by considering physicians as being superior to their patients. So if you've ever been a patient, you know that this is true. You know, we come to it from the side of being the physicians and the nurses and the healers, and we like to think that the patient is on the same level of us, but they really aren't. If you've been a patient, you know that you're in a cold hospital bed, you're wearing a thin gown, you're not wearing your own clothes, you're not in your own home, you don't have your own books with you, and you're really dependent on the physicians and the nurses to take care of you. Even if you are a very intelligent person, you may not have the resources available. You may not have your cell phone charger, you may not have your books, you may not have your computer. You may not be able to look up all the literature that you need to have the adequate and full knowledge to discuss your condition with your patients. And in some Hippocratic documents, the patients were actually expected to place themselves fully in the physician's hands and obey their commands. So this really shows how there is some paternalism that goes back to the Hippocratic Oath. So what's paternalism? It's an action taken by one person in the best interest of another, allegedly, but without the patient's consent. And there's two different types. There's strong paternalism, and that's when we take an action against the wishes of somebody who's competent. We don't see a lot of that in medicine, thankfully, but what we do see is that to this day, we still use weak paternalism, which is when we take actions under the presumption of somebody's wishes, but they cannot consent because of age or mental status or something else. And so there are people that defend weak paternalism in medicine. You know, for example, doing research on children. Children cannot give consent because of their age, but we still give them chemotherapy, drugs, and other things and study drugs on them because we think that it's in the best interests of the population. So going on with this concept of paternalism, sorry about that. Patients who are hospitalized, who are already vulnerable because of their state of illness, are likely to experience distrust and fear due to this pervasive nature of Hippocratic practices and paternalism that still exist every day in medicine. we are biased as physicians. We have our own opinions on many things, including blood transfusions, that can further exacerbate that concept of paternalism and Hippocratic practices. So it's been well studied that physicians think that blood transfusions are not really dangerous, that they have few risks, and that the risks are not as severe as other things that are out there compared to what laypersons think. So while we are generally very comfortable giving blood transfusions because we give them every day and not that many people have problems with them, we are going to just be inherently biased and tell our patients this transfusion is safe, you can take it. And even though the patients may not think the same way, we are in that unequal position as physicians and caregivers where we are going to convince the patients of that. So moving on, Hippocrates is still pervasive in our culture. Paternalism is still there. But in the 20th century, we sort of switched from this model of pure beneficence and non-maleficence to autonomy. And again, autonomy has been discussed before. I won't go too much into it in the interest of time. But autonomy really came about after the end of the Second World War. After the end of World War II, we were becoming much more aware of individual rights and civil rights, and people were going and getting higher education in greater numbers. And society was really growing, and thought processes were emerging that allowed us to be much more cognizant of rights and responsibilities of individuals. What does that mean for the Jehovah's Witnesses? Well, back in the 1930s and 40s during World War II, there was this huge expansion of blood product utilization. Blood products were being used in the war, and blood banks were proliferating across the world. And we were coming up with these new concepts of, using blood for cardiac surgery to save lives, and treating hemophiliacs and other conditions that required blood. And blood product usage was expanding tremendously in the post-war era. This coincided along with the Watchtower's initial ban on blood transfusions that occurred in 1945. And so this is where the initial discordance between the Jehovah's Witness community and medical professionals started, was back in the 1940s. But actually, that actually turned 180 degrees about 20 years later, when the AIDS epidemic occurred and people became very, very concerned about the actual risks of blood products. And so in the 70s and 80s, we started going and looking towards ways of minimizing uses of blood and blood transfusions. But the damage, unfortunately, had already been done. And there were many publications in the 50s and 60s about how Jehovah's Witnesses were, not following in the best interest because they were not accepting blood and all of these things. So the damage was done in the 1940s, so about 90 years ago. So where does this lead us with informed consent? So again, after World War II, informed consent became recognized. So this is actually quite interesting to me. And we didn't really have a concept of informed consent until the early 1900s. And then in the post-World War II era with the trials of the Nazi criminals, this established the Nuremberg Code, which really emphasized the importance of informed consent. But informed consent didn't obtain its formal name and legal recognition until 1957, when there was a landmark court case against Stanford University, where a man basically went in for an aortic surgery procedure, became paralyzed, and sued. And the judge in his ruling identified the lack of informed consent and why this was important. So informed consent is a relatively new concept. It's only been around for like less than 70 years, which I find fascinating. But again, that may be why we are not always using it as best as we could, because it's a relatively new concept. And we are still evolving in our practice of medicine as to how to best understand and utilize informed consent. So there are multiple principles of informed consent, including voluntarism, decision-making capacity. I think we all know about decision-making capacity. That's one of the most important things that I learned as a resident and student in getting informed consent. You want to make sure that your patient has capacity. These other factors we didn't talk about too much: disclosure and understanding, and actually having the patient make the decision. And then voluntarism. What's voluntarism? So voluntarism means that the patient needs to be free of coercion and unfair persuasions when they undergo informed consent. And coercion is the inappropriate pressures from institutions or individuals that keep us from making independent choices as patients. So I chose this picture for this slide because this is how doctors are presented in the media. And if you look on a hospital website, the pictures of the doctors always tend to look like this. You have your arms folded, you look powerful, you look like you're in control, and you can tell the patient what to do. Well, that's a problem because then this is where coercion comes in. So we see this a lot with the bloodless medicine patients. I don't think in my hospital, but we hear this from patients who come from other hospitals. They are definitely undergoing coercion when people separate the witness patients from the HLC or don't let their relatives in the room with them and try to convince them to take blood products. That's coercion, in my opinion. If we don't disclose the risks of the risk and alternatives of transfusion to the witness patients, that's also an adequate disclosure. And if the patients do not have a full understanding of their condition, that also limits their ability to give informed consent. Some people might say, well, this doesn't happen. Well, I can tell you it does. I actually wrote a ethics article and submitted it to an ethics journal about a month ago. And within the last couple of weeks, I got the reviewers' responses back. And one of the reviewers actually suggested that I talk about how Jehovah's Witness patients are ostracized from their community if they take blood. And that is obviously not true. But again, this is something that's perpetuated. And if a medical ethicist expert thinks that it's true, I can only imagine what a typical physician would think. So we do need to be aware that these limitations to informed consent occur, and we need to be aware of the importance of taking into account all of these factors of informed consent when we take care of bloodless medicine patients. So how do we support anemic patients with compassion? So we do need to understand the limitations of that Hippocratic model of ethics. We need to eliminate coercion, achieve adequate disclosures of risk and benefits, and then optimize our patients' understanding of the procedures and the risk and benefits and the alternatives to transfusion. So let's just go back to the opening case. So in the case that I described earlier, why did the hematologist send the patient to palliative care and tell the patient that nothing else could be done? I actually don't know the answer. I'm just going to leave this for you to think about on your own. Some possibilities are maybe the physician's values were just inconsistent with those of the patient. I don't think the patient was trying to be uncompassionate, but maybe the values, the pathway of healing that physician had was different than that of the patient. I think that there was inadequate disclosure, and that might have been related to a knowledge deficit on the part of the hematologist, that they just didn't know that there were alternatives to, if iron doesn't work, that there's other things that can be done with the patient to enhance anemia. But then I think that we do have to consider the impact of stress, and certainly maybe the hematologist was very stressed because his patient had a critically low hemoglobin of 2 or 3, and he was stressed, and stress begets fear, and fear causes a lack of compassion. So what can we do differently? We need to be aware of paternalism and try to eliminate it, although I will say that that's going to be very difficult to do, and that will probably take decades for us to finalize in medicine, since it's so deeply entrenched in our system. We need to enhance patient disclosures of alternatives and be aware of them. Make sure that our patients are aware of the alternatives to their condition, to the treatments for their condition, and we need to be aware of and try to reduce the impacts of fear and stress, because those are going to alter our ability to be compassionate. Thank you for listening. If you have any questions, feel free to email me or give me a call. Thank you.
Thank you very much, Dr. Johnson-Abor. This is after the fact, but I'm going to request that you please stay on for just a minute while we do what we should have done in the beginning, and which is to tell our audience a little about you. So Dr. Kelly Johnson-Abor is board certified in emergency medicine, medical toxicology, and undersea and hyperbaric medicine. And currently she serves as the medical director of hyperbaric medicine at MedStar Georgetown University Hospital in Washington, DC, where she maintains medical toxicology. And hyperbaric medicine clinics and regularly teaches medical toxicology and hyperbaric medicine topics to third and fourth year medical students, residents, and pharmacology students. He is an associate faculty member of the MedStar Institute for Quality and Safety. Incidentally, I got a certificate from that institute in bloodless medicine and surgery. An international training center for bloodless medicine and surgery. Dr. Johnson Arbor is an instructor for introductory hyperbaric medicine courses, has authored multiple published medical articles in toxicology and hyperbaric medicine related topics. And she enjoys speaking on these subjects as well. Well, you could see that. Her current research interests include the use of hyperbaric oxygen therapy in the bloodless medicine population. Dr. Johnson Arbor is a member of the Society for the Advancement of Patient Blood Management, among many other professional societies. Thank you so much, Dr. Kelly Johnson Arbor.
Thank you, Dr. Yusora. Thanks, Kelly. I'd like to proceed to our next speaker. I'd like to introduce Dr. Christopher Simuto. Dr. Simuto's journey in medicine began at the University of Zambia, where he earned a Bachelor of Science in Human Biology and later his Bachelor of Medicine in Surgery. He did his postgraduate work at the Royal College of Surgeons in Ireland, and he received the title of Fellow of the Royal College of Surgeons in Ireland. He is a Fellow of the Royal College of Surgeons in Edinburgh and the College of Surgeons of East Central and Southern Africa. Over the years, Dr. Simuto has held significant positions, including serving as the medical superintendent of Kasama General Hospital and the provincial health director of Northern Province in Zambia. His clinical expertise expands many things, including managing multiple trauma patients, general surgical conditions, orthopedic surgery, urology, obstetrics, and gynecology. That's a lot. Dr. Simuto's commitment to education is evident through his past involvement in teaching at various institutions and his contributions to the College of Surgeons of Eastern, Central, and Southern Africa. He has played a pivotal role as an examiner, contributing to the University of Zambia and the School of Medicine for Copperbelt University. Currently, Dr. Simuto serves as the consultant surgeon at Luanja Copper Mines in Zambia, where he manages a wide array of surgical conditions for mine employees and registered members. He has been providing bloodless medicine and surgery service since 1989. And it says he's close to retirement and he's going to start a private practice providing bloodless medicine services. And welcome to Dr. Simuto.
Thank you very much. I'm going to present bloodless surgery techniques in a low resource setting. The layout of the presentation is as follows. I'll present two case studies, clinical cases. Then after that, we'll discuss key components of successful bloodless surgery, focusing on good surgical training, adequate preoperative preparation, strategy for intraoperative management, and a detailed post-operative monitoring plan. Our first case. This is a gentleman, 40-year-old gentleman, who presented with abdominal pain, which was associated with episodes of diarrhea, but there was no vomiting. On examination, clinically, he was pale. The conjunctiva, the palm, the blood pressure was fairly okay. The pulse, a bit of a tachycardia. And on examination, when lying flat, you could see the fullness in the left hypochondrium. And on palpation, there was a definite palpable mass in the left hypochondrium extending up to the midline. The rest of the physical examination was normal. Okay. On the investigations done, the abdominal ultrasound confirmed the mass in the right hypochondrium, which is an enlarged spleen. The full blood count showed an HB of 8.1 grams per deciliter and white cell count of 2.3. The film content showed signs of iron deficiency anemia. Management of the patient. The patient presented with features of hypersplenism. This is a condition where the spleen gets very overactive and starts destroying blood, mostly the red blood cells. And after discussing with him, he was reluctant initially to undergo an operation. And we gave him time to think about it. And in the meantime, we just put him on oral ferrous sulfate and folic acid to build his blood. After 1 month, he came back. He was more confident. And this time he agreed for surgery. The pre-operative management that we did showed that the HB was 9.6, it had gone up. And the fact that he didn't want any blood. But at 9.6, we were comfortable to proceed with the operation. So we went ahead with a laparotomy to do a splenectomy. This involves using a long midline incision, making sure that we get all the bleeders. And then in the abdomen, the spleen was quite big. It's easier to remove a big spleen. We were able to get all the blood vessels quite well attached to the spleen. And the patient recovered well. Post-operatively, after a week, the hemoglobin had come down slightly to 9.2. And that is the spleen that we removed. It weighed 950 grams. The normal spleen is really about 30 to 50 grams. And those are the features, which was clinically like a tropical splenomegaly. In the tropics, we do get a lot of parasitic infections and malarias. So usually we get a lot of spleens which are quite enlarged. The patient was seen back after 4 months and he was in good health, and his hemoglobin was 9.6 and platelet count was okay. He recently came back to see me just to bring another patient who was anemic. He's in good health. If we go back to the pillars of patient blood management, where initially we need to optimize the hematocrit, which we did on this patient. Initially it was low. We just put on oral hematinics, which helped to bring the blood high up 9.6. The second pillar, minimize blood loss. The surgery was quite good, meticulous, making sure that we actually didn't lose much blood, and he did very well. The same pillars of bloodless surgery, optimizing hematocrit, which we did, minimizing the blood loss, which we took meticulously during the operation as well, until we recovered quite well. Okay. The second case we had is a 36-year-old gentleman who was a driver. He was involved in a road traffic accident on 3rd September 2012. He was denied treatment at 2 hospitals because he refused to receive blood transfusion. So we received him at our hospital after 1 week. The accident was on 3rd September. We received him on 9th at our hospital. He had sustained fractures of the bones of the right leg, upper leg, the thigh, and also the right lower leg, the tibia and the fibula. Okay. So these are the other findings. And the HB was 6.5 grams. Okay. The plan that we made for him was to raise the blood level, and we divide the operation in 2 parts. The first operation would be done on the lower leg, then the second operation to be done on the upper leg. And this was to reduce the blood loss if one was to do an operation in 1 day. So during the pre-operative period, we put him on skin traction, and he received iron sucrose, 5 mils in 100 mils of normal saline burette on alternative days. This is how I treat my anemic patients. And they also give an erythropoietin, 4,000 international units intravenously daily. After almost a week of treatment, by 17th September, the hemoglobin has gone up to 9.7 grams. And at this level, the decision was made to proceed with the operation. So what we did was an open reduction and plating of the tibia and fibula. And during this operation, we put a tourniquet on the thigh to reduce the blood loss. He recovered quite well, and we continued monitoring him, and his hemoglobin was rising as we were operating on him. Just this one. So on 21st September, his hemoglobin had risen to 10.5. And on the 28th September, his hemoglobin had risen to 12.4. I think maybe you can't see that from there. And hence, another decision was made to actually do a second operation, which was done on 3rd October. Okay, this was now an open reduction of plating of the right femur, the thigh. Okay. So the post-operative period of this one, the HB came down slightly to 10.3. It was closely monitored and finally discharged on 10th October the same year. The condition is well, he's back driving around the long distances. Again, if we go back to patient blood management pillars, optimizing hematocrit, which we did, he came initially with HB of 6.5. We managed to raise it high up and he was fit for surgery. During the operation, we managed to minimize the blood loss. We supported his anemia. The same pillars of blood surgery, again, we optimize the hematocrit, minimize the blood loss, and optimize the oxygen concentration. The key components for success, I think in our area, one needs to have a very good surgical training, and one needs to have adequate pre-operative preparation, and one needs to develop a strategy for intraoperative management. And then we want to have also a detailed plan for post-operative care. In good surgical training, it's important that a health worker certified to carry out surgical operations is adequately trained and qualified. He should be competent. The essentials that he needs to have is he needs to have a good anatomy, knowledge of anatomy, a good physiology, and pathology. He must know the surgical operation techniques to be able to carry out operations. Okay. Patients should be adequately prepared. We need to really comprehensively prepare the patient. We should do all the necessary investigations and address the problems before operation. The emergency tools which you should always have available is tranexamic acid, vitamin K, IV fluids should always be there, a tourniquet when it's needed, and bandaging or packing, depending on the type of operation one is going to do. So in all elective cases, we need to treat issues like anemia with iron sucrose and erythropoietin. This is the standard I use. It's important to develop a strategy for intraoperative management. For every operation one is doing, we need to review the operation steps. It is very important, okay? And then so that we need to anticipate the potential problems we might face while operating. And for every surgery, it is important to understand vascular anatomy. By knowing the vascular anatomy, you can avoid some of the bleeders that you can come across. And you will know if you come across a bleeding, where it's coming from, and how to stop the bleeding. It is very important to brief the theater team. As the operating surgeon, your assistant should know what you're going to do, should know your steps. The scrub nurse should know what you're going to do, should know the steps. The whole team in operating theater, if they understand you and they know what you're going to do, they can assist you in the operations and things can work very well. The essentials during operations, that 2 IV lines, as I said, tranexamic acid is a key. And we need to make the first proper incision. All this with careful planning, one can do well, and usually patients can recover quite well. The post-operative period is equally critical. So we need to plan how to look after the patient very well. Close monitoring, the blood pressure, the pulse, the temperature, in case there's a bleeding that has occurred. So it is very important to closely monitor the patient. Vigilance for any potential complications that might come, we should always be alert. Okay. So in summary, again, just to emphasize the importance of training, one needs to have a solid foundation of surgical training and surgical practice. We are able to handle complex cases in a low resource setting with good training, and the importance of understanding the human body, the intricacies, and also the surgical techniques. Under surgical techniques, I think even how to handle artery forceps, how to handle the sutures, how you make your knot, all these one needs to be knowledgeable to this, so that if you don't tie someone nicely, they start bleeding, post-operatively, those are complications that with a good understanding of surgical techniques, you can actually do quite well. Preparation is key to reduce complications. Let's always conduct the necessary investigations and address arising issues which can come. And then intraoperatively, a clear strategy for smooth surgery is important. Still emphasizing vascular anatomy, you need to do this, you need to know this. If you're going to do a thyroidectomy, any laparotomy, it's important to know the vascular anatomy so that you can be able to do a good operation. Briefing the theater team. It's very important that as a team, they all understand what is happening, and then things will be fine. Let's have necessary equipment at hand, which is very important. So postoperatively, the close monitoring of patients are always very important. So in conclusion, it is possible to have a successful outcome of bloodless surgery in a low-resource setting. With good training, good strategy, it is possible to achieve quite good. I think that was my brief presentation. Thank you.
Thank you very much, Dr. Sumito. We'll have some time for some questions and answers.
While checking for the questions and answers, Richard, if you don't mind, if Dr. Shanda has some comments you would like to make on the presentations.
Thank you.
They're excellent.
That covered it all, I guess.
Yes, somebody has a question.
I see a question here that hasn't been answered. I don't know if any of our panelists can tackle this one, but it says it seems that the court doesn't allow parents to decide what is best for their children, minors. So what to do with minors, what to do so that minors can benefit also from bloodless programs.
Good point, Linda.
Ogaga.
Very, very good point. I think the first thing to do is never to get to the point where you need to get the legal system involved. You know, we talked about compassion, we talked about bloodless, we talked about all these things, and I think that what's important is to understand that communication is paramount for good success. So that I think that talking to the families, making sure we understand what the local laws are, and then acting in such a way that it's a cooperative approach. Parents understand that we need to comply with the law, and the law, at least in many states in the United States, requires that if there is an intervention that is deemed to be either limb, organ, or life-saving in the child, that we act to do the best to, again, make the individual not only survive, but the organ as well as the limb, which may require transfusion. If everyone is on top and understands what we need to do, and that we're very cautious not to do this flippantly, meaning just to give transfusion whenever we feel like it, but it meets those criteria, everyone understands and will not stand in the way. But the minute we go to court and get a court order, at least the US and in Western Europe, the Child Protection Agency takes over, and therefore the parents have no longer a sort of a legal oversight over their child, which is another conundrum that creates a lot of tension for everyone. The only other caveat, of course, is when it's a minor, meaning it's a child, but has full capacity. So I used to say that, again, if you're 17 years of age and 360-day old, you're not going to be a different person in 5 days when you become legal. So under those circumstances, there are some provisions in some areas where we can actually determine that the minor is actually mature enough to, again, undergo the same the same procedures that we do with an adult. We do that in criminal courts, and there's no reason why we can't adopt the same thing for a mature minor who understands the consequences of going against their beliefs or principles. But again, that creates that has to be done with a coordinated effort by both hospital, legal, and the risk management, as well as the clinicians taking care for that patient.
So we do have a question for Dr. Shore. How often are patients ineligible for PBM programs such as multiple comorbidities and low physiologic disease?
Great, thank you. I see that's the question from Dr. Su. Thank you very much. You're absolutely right. Then we're talking about cardiac surgery patients, and there are many excuses that are used, and there are also some truisms. And the truth is that many of these patients have limited cardiovascular reserve. But PBM is really unique in that it is multifaceted and multidisciplinary. And so in these patients, we often pick and choose those procedures that are relevant and able to be practiced. So oftentimes a 3-week period of preoperative hemoglobin building is not available. Oftentimes the limiting the hemodilution by drawing off the patient's own blood sort of techniques like ANH or wrapping are not able to be performed in a patient who's critical. But there are things that can be done in pretty much all patients, even those that are moribund. For example, an intraoperative dose of iron has been shown to be beneficial to the postoperative hemoglobin development of appropriate hemoglobin numbers. The following of coagulation profiles when transfusing either pharmacologic agents or allogeneic blood products is a very rational approach that doesn't really rely on the patient's physiology to approach it. So I would say it's really an individual patient practice, and we pick and choose those that are available for the patient, for their health and status, and those that are not available. And also, if it is a bloodless patient, then we certainly engage in these conversations prior to surgery and make sure that the communication is out there on the table, and that all of the accepted procedures are abided by, and those that are not acceptable are acknowledged.
Thank you.
Thank you very much. I invite the moderators for the industry presentation, please, and other questions may be answered in writing, and you may so inform. Please have your answers in writing since for the speakers. Thank you very much.
Yeah, thank you. So good morning, good afternoon, and good evening, depending on the part of the world you're tuning in from. So you're welcome to the industry presentation session of 9th Visual Annual Scientific Conference at AGM here. So my name is Paul Agbulu. I am the project lead for stem cells at the Canadian Blood Services here in Edmonton, Canada, as your moderator. So with me as a co-moderator is Tiffany Hall, who is the director of PBM Clinical Technology at Acumen, Orlando, Florida, in the US. I will hand it over to Tiffany to introduce herself and our industry presenter.
Thank you very much, Paul. Really excited to be here today. And thanks for that kind introduction. I hope everyone's enjoying this wonderful conference. It's been fantastic, the presentations I've been able to see. And I think it really helps to underscore the importance of compassionate care. I love the theme in the practice of bloodless medicine, with the overall goal to improve clinical outcomes by managing and preserving the patient's own blood. Again, part of our definition for global definition from PBM, but while promoting patient safety and empowerment and protecting patient rights. So I think this really, of course, highlights the importance of blood health and what interventions we can use to preserve patients' own blood. So I think this industry presentation will be really timely in this topic. Really like to introduce our presenter, Dion Assen Wengi, who is the Global Business Development Manager for HemoClear from the Netherlands. And Dion will be discussing how HemoClear product can support blood health through cell recovery. I'd also like to share before I hand it to Dion that we are honored to have in attendance today Dr. Anai Jamo-Subru, who is the Director General for the National Blood Service Commission in Nigeria, who he may like to give a few comments at the end of Dion's presentation. I would like to hand it over to you, Dion, and welcome you to share your presentation topic, Boosting Autologous Blood Use in the Obstetric Setting by Microfiltration and Cell Recovery. So Dion, if you want to share your screen and presentation, we look forward to what you have to share.
Thank you so much, Tiffany, and thank you for having me. It's always a pleasure to be a part of this society's meetings. So I'll go ahead and share my screen. As Tiffany said, today's presentation is about boosting the autologous blood use with microfiltration cell recovery. And I think that when we talk about patient blood management and the three pillars thereof, cell recovery is, I want to say, in the back of your mind, but it should be in the front. Everyone here could probably do a phenomenal job in explaining the importance of cell salvage, cell recovery in patient blood management. Today, I mentioned that centrifugal technology does a great job at effectively capturing the red blood cells, as I'm sure you're aware of. Very good in washing away the bacteria and the cellular debris they ideally don't give back. But there's also some downsides to this technology. It's complex, there's costly equipment, and therefore it's confined to the operating theaters that can afford to always have these machines and have the required dedicated operator that's necessary. In the lower resource settings and anywhere that the bleeding risk is not very well predicted, the machine oftentimes isn't practical, not available, not affordable, and they aren't an option. This lack of a widely usable technology, apart from the centrifugal cell savers, remains a limiting factor in using high quality autologous blood worldwide. So HemoClear, HemoClear was invented as the first microfiltration solution for cell recovery to boost the autologous transfusion options in those procedures where cell recovery before wasn't possible. And the invention, as done by Dr. Arno Nierich, is exemplified by that. He was very happy using cell savers in the operating room, but then when taking care of the patient in the ICU, also being an intensivist, he had to revert back to using donor blood because the technology wasn't available. So HemoClear does the same thing as a cell saver, but it does it so with an easy filter procedure. No equipment is needed. High quality washed product is produced in a simple 30-minute procedure. And as a bonus, the blood platelets are also recovered. So this is obviously marketing representation of the procedure, but in a nutshell, the blood is collected similarly to what you would be used to with the cell saver. For HemoClear, it is transferred to the processing setup, the second picture, and in 2 filter rounds, 30 minutes, a high quality washed blood product is produced that can be reinfused to the patient immediately. Today, I focus on the use of microfiltration recovery in obstetrics. There are reports of the obstetric department of hospitals representing about 40% of the donor blood consumption. PPH and anemia in pregnancy greatly still contribute to maternal mortality worldwide, and as well described in literature and explained by some of the leading physicians that are also among us here today. obstetric care might have the most to gain in terms of patient blood management and broad use of autologous blood. And in thinking of this, the first consideration is, of course, safety first. So to validate the microfiltration cell recovery for the use in obstetrics specifically, a study was done. This was done in the UK, and the setup was to evaluate the washing efficiency of Hemoclear, compare it to the gold standard Cell Saver, and ensure that the blood quality produced was comparable. Here you see two graphs, a snippet of the results. The setup was such that blood was collected in cesarean sections. The volume was split in two equal volumes. One was processed with the Cell Saver, one was processed with Hemoclear. And for alpha-fetoprotein, as shown here, a marker of amniotic fluid, and heparin, the results were comparable in the sense that both technologies reduced the alpha-fetoprotein and heparin to a significant level compared to the pre-processed sample. Having validated the safety and effectiveness of autologous blood and the use of Hemoclear to produce that autologous blood, then the next question is, does microfiltration also meet health system and adoption requirements? Because having safety and effectiveness obviously isn't enough to well integrate it into transfusion practices worldwide. And this translates to various questions as were explored by the VU University. Apart from safety and effectiveness, there's also stewardship. Is there financial feasibility to implement a system both in high-income countries but also in lower-income countries? What is the best implementation plan? What clinical guidance is needed, etc. And while we continue to collect data to reconfirm and keep confirming clinical safety and effectiveness, as in South Africa and Germany, upcoming trials, in order to answer those health system and implementation questions, we will shortly start a real-world trial in Nigeria. And we do this with a very special partner, namely the National Blood Service Commission. And I'm very excited and thankful to be able to pronounce this partnership here today. As the NBSC is a national expert commission and regulator of blood transfusion practice in Nigeria. Second partner is the FIT Fund. It's somewhat premature to share because we are yet to finalize the paperwork, but assuming that no surprises will pop up, they will fully fund this project. So what does it look like? To give you a flavor of it, the pilot is really, or the trial is really a pilot to implementation of microfiltration cell recovery, and to understand what are the clinical and practical support requirements to effectively implement and have it adopted. It will run in 2 hospitals for 6 months, 2 tertiary centers. And during that period, is expected that about 300 participants will enroll. The main focus initially will be situations in the obstetric and gynecology department where bleeding is controlled. So cesarean sections and hysterectomies. And when confirmed that the system is used comfortably and with the right outcomes, the setting will be expanded to also scenarios of uncontrolled bleeding. As a control, the data on transfusion practice will be, and patient hemoglobin levels will be collected prior to implementation of the cell recovery by microfiltration, so that we have something to compare on. So that's it for me. That's it from me for today. As I said, I'm very excited to announce the partnership with the National Blood Service Commission. And I'm also very happy that Dr. Suberu is here today with us as the Director General, but also someone that inspires me with his wealth of expertise. Thank you very much for being here. And I gladly give you the final word for some comments on the partnership and a project ahead. Thank you.
Thank you. Dr. Subaru, you want to give a few comments? It would be great to hear from you. You're still on mute.
Good afternoon, everyone. Good morning, good evening, wherever you are calling from. Dr. Suberu is my name, and I'm the current Director General, National Blood Service Commission. And I must say that we're happy with Dion there for the beautiful presentation. And of course, she has our support because anything that has to do with blood and blood products is the responsibility of the National Blood Service Commission to control and in charge of. So we're happy having this relationship with Dion, and it's really fine. You know, the mission of our organization is to provide through regulation and coordination, safe, quality, and adequate blood in an adequate and cost-effective manner to all people resident in Nigeria. Not just those resident in Nigeria, we are praying and hoping that with time, we'll be serving the African sub-region, just like our sister South Africans are doing currently. That is it. And our vision here is to have a national blood transfusion system that ensures safety, quality, and accessibility of blood and blood products to all residents in Nigeria in compliance with international standards and acknowledged as one of the best in Africa. And again, sir, we are happy because you discover that in sub-Saharan Africa, the difficulty of coming by blood is just something that is mind-boggling. And if we have a situation whereby we can do this bloodless that the other young man presented, and again, not just bloodless, but making sure that we use autologous blood, that is taking blood from people who actually taking their own blood and transfusing this blood to them. I think it will go a long way into helping our society, especially in our area here, where canvassing for blood for people to donate freely is really not easy. We know what we go through because of some of the myths that people have here, and they believe that blood is something else, not like in the Western world where we know that blood, once you give blood, you are giving life to so many people. So thank you, Ms. Dion, and thank you everyone for this little contribution I have to make.
Thank you,
Thank
Dr.
you very
Subaru.
much.
Yes, thank you. We could take a few questions. There are a few questions. I know, Paula, are you able to see in the Q&A chat? The first one is HemoClear available in Southeast Asia, Dion?
So HemoClear is available in Malaysia and Hong Kong, and the other Asian countries we are still working on.
Thank you. Paul, you want to take the next question?
Yeah, so the second question here is, when do you plan to hold a pilot for HemoClear in Nigeria?
So as said, we are laying the final hand on the paperwork for the funding, and we look to start the first steps in January of next year.
Excellent. So can you give us an idea of the cost of HemoClear, the whole system, disposable, or is it only the filters? Does the system include a suction unit to collect blood? I think it's a three-part question.
So the suction unit is not included for the simple reason that generally people have their own preference and materials to collect blood in the way that they're already doing. So it's the kit that processes, and it depends per country. But in all scenarios, it will be more affordable than donor blood and at least as cost effective as a cell saver.
Great. Paul, you want to take the next one?
Yeah, I think that's all we have.
Oh, I see one more about, is it available in Ghana?
Okay.
Sorry.
Yeah, I think,
training.
thanks. So
I just saw that one. I think it just came up. So they're asking, is it available in Ghana, and does it require special training to enable a clinician to use it?
Okay.
It's not registered in Ghana yet, so no. But it requires some training, as all devices, but not very extensive.
I see one more that was a comment that actually had a question embedded in there, Paul. I think it says, thank you, Deanna. I enjoyed your presentation. A recent case. Can stomach acid be separated from blood using any of your machine?
I don't have any data on that, but in theory, anything that is fluid or molecular, so smaller than the micropores, is washed out, and in theory, stomach acid should also be washed out.
Yeah, I think we have one here. Is it available in Philippines?
Not yet available in the Philippines.
Okay.
You're working hard to bring it across the globe.
Okay. Thank you very much. So I want to thank my co-panelist, Stephanie Halls, our industry presenter, Dr. Semgwe, and our Dr. Suberu from the Nigerian Blood Services. Thanks for your engaging attendance. We look forward to another engaging session tomorrow, starting at 8 a.m. Eastern. So there'll be 3 sessions. The first session is with the team Bloodless Medicine and Surgery. And we have moderators, Dr. Majid Rufai, Rebecca Rock. And we have 3 topics. First topic is a keynote titled Plasma Transfusion and the Story of Adverse Outcomes and Lack of Efficacy. That will be delivered by Dr. Carolyn Bonds. Carolyn Bonds is the president of Surgical and Bloodless Medicine and Chief Medical Officer at the Collaborative Clinical Consulting in the USA. We have a second topic, which is what is wrong with platelet transfusion, to be delivered by Dr. Nell Blomberg. And the third topic, the massive hemorrhage protocol in bloodless care, by Dr. Erin Sordem. The second session, it's with the team, the Art of Bloodless Medicine, with moderators Dr. Amit Shah and Sandy Mann, with topic bloodless renal transplant, music, sculpture, and other forms of art by Dr. Nadi Hakim. And the third session is an annual general meeting, which will be chaired by Dr. Nat Osoro, the BMSS president. Thanks again for your attendance today. We look forward to seeing all of you tomorrow. Thank you very much.
Thank you. See you tomorrow. Bye-bye.
Thank you very much. So, Arjun. Arjun, you're the only one who can close the session, so you're free to.
Can I just say I appreciate everything, because I won't be here tomorrow, and so I will not have the opportunity to speak to anybody. So, and I also want to say my daughter was refused blood transfusion when she was not up to a year. But the host at that time, what they are doing was not very known. in Nigeria. So, but fortunately, I had my uncle who took after the states, the medical system just sent her to go and die. And now she's making sure she's now a medical doctor for some years in Edinburgh now. So wow. I really appreciate what you people are doing.
That's
Thank you
nice.
very much.
Thank you. Thank you. I'm a living testimony to that.
Yeah, I'm so glad you spoke up, Abel, because like you said, you're not going to be around tomorrow.
Yeah.
And I really should acknowledge you. Abel is my elder brother, eldest actually. And he's a volunteer to help us with this program. And I really appreciate that. I know you have to travel and so you won't be around tomorrow. Thank you very much, Abel.
Thank you.
Thank you. And
thank you, everyone.
Thank you. Arjun, you're free to shut down. You are the host. I have no powers. And thank you very much,
Yes, I'm
everybody.
going to shut down. Thank you.